Yeah, we can start now.
Yeah, ma'am, we are on live and we are starting now. So,
Okay.
very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's live webinar organized by IFS South Tamil Nadu and Pondicherry. I'd like to welcome all the participants, and I would like to invite and introduce the conveners for today's program, Dr. T. Ramani Devi ma'am and Chitra ma'am. So Ramani Devi ma'am needs no introduction, but as a formality, I need to introduce her. Madam is currently the Managing Director, Ramakrishna Medical Center and Genetic Fertility Center. Madam has won 10 gold medals during her UG PG periods. And Madam was the chairperson intermediate committee of Foxy 2014-16. And Madam has received various awards towards her service and credit. Madam has, I will name few here. Madam has won the Woman of the Year Award by Bhadas University, Woman Achiever Award, Dr. APJ Abdul Kalam Award, and Dr. Navamani Bose and Dr. Rameshwari Nallasamy Oration Award. And Madam has also received SN Pandit and Shailaja Pandit Award, Best Woman of Doctor Award by Tamil Nadu State Indian Medical Association, and recipient of Ashraf Award, and recipient of Dursha Distinguished Community Service Award. And Madam was as actively working as peer review member and editorial board member in various journals. And Madam was also the patron of Tamil Nadu Federation of Obstetrics and Gynecologists. And Madam was the EC member, Society of Vaginal SOPSI India, TN chapter. We welcome you, ma'am. And I'd like to introduce Dr. Chitra Tyagarajan ma'am. Madam is currently the professor at JIPMER, Pondicherry. Madam has received various awards like Purnima Natkarni Award for Best Paper in ISA 2020, and Srimati Shanta Anji Gold Medal Award for the Best Paper in IFSI, KD Nair Award for the Best Paper Presentation in IFS 2018, and Dr. Asha Rao Award for the Best Poster Presentation. And Madam has also received Wonder Function Award in 2019, presented by Foxy President. Madam has also has various publications in national and international journals, and also authored a few chapters in textbooks. Madam's area of interest is reproductive medicine, laparoscopy, and medical. So, ma'am, we welcome you, ma'am. I'm handing the section to you for your further proceedings.
Thank you so much, Dr. Stalin, for this kind introduction of myself and Dr. Ramani madams. So without any undue, we like to start this program. So I request Dr. Ramani madam to give the welcome address for this webinar.
Good evening, everybody. Respected Sir Dr. KD Nair sir, Survin madam, and Dr. Rajapriya Ayappan, who is the Secretary for Tamil Nadu IFS. And I'm happy to say that her chapter won the best chapter in the recent IFS conference. And welcome Dr. Chitra, who is the co-organizer for this particular program. And she is also the Secretary for Pondicherry IFS. Dr. Papa Madam and Dr. Rajapriya Ayappan, who are going to be the speakers today. And the two topics that has to be the planned for today are very, very important. One is about premarital counseling, Dr. Rajapriya, and the other one is about poor ovarian reserve. I think this topic is again very important because nowadays see even young girls coming with poor ovarian reserve. And the third topic will be a panel discussion on adenomyosis and infertility by me. And I have a very good expert panelists like Dr. Kalpana, Dr. Chitra, Dr. Jayashree, Dr. Again Chitra Tyagarajan, Dr. Gajadiban, and Dr. Nandini. And we have again Dr. Nirmala Vijayakumar with us, and all the participants on behalf of IFS South Tamil Nadu, IFS Tamil Nadu, and IFS Pondicherry. I wholeheartedly welcome you for this program. And I also welcome Dr. Uma Vailmurugan and Nirmala Vijayakumar, who are going to be the chairpersons for this.
I think some network problem.
To see Professor K, because we know it is very difficult to
Yeah. Ma'am, your network. Thank you, ma'am. Thank you for welcoming the gathering. So now I'd like to introduce our.
I will stop my video.
Ma'am. Dr. K.D. Nair, sir, who is present president of Indian Fertility Society, the chapter. Then he's a chief consultant and HOD of Akanksha IFS Center from New Delhi. He's a director for Foxy Certified Infertility Trainings, Basics and Advanced. He is a supervisor for 1-year fellowship in clinical ART and also in clinical embryology. He has been holding a lot of executive posts in various societies. So we are very happy that sir is here to inaugurate this webinar and please, can you tell few words?
Chitra, I would like to add up. Sir got the 3-star awards for the last consecutive 3 years from ASRM.
Oh, very nice.
That was really a very great achievement.
Oh, very nice, sir. Can you unmute, sir, please? Stalin, can you unmute, sir?
Yeah, now is fine.
Yeah.
Good evening, ladies and gentlemen. It's a pleasure for me to inaugurate this webinar and a lot of amalgamation, IFS South Tamil Nadu and IFS Pondicherry chapter. The chapter I had inaugurated, and the speaker is from IFS North Tamil Nadu, Dr. Rajapriya. It's a wonderful thing that all the 3 chapters have joined together and leading this webinar. And I bring you greetings for 4,000 IFS members spread all over India, 29 chapters.
Congratulations.
I again congratulate Dr. Ramani Devi. I had joined her webinar a few days back. She has been very active, and we want her to take this basic gynecologist webinar to other chapters also, because that is what we are needing. That is the need of the hour, that the basic gynecologist should know how to tackle the infertility problem. Today's topic, premarital counseling, is a very important topic, and I am very sure Dr. Rajapriya will do complete justice to this topic. And poor awareness reserve is my favorite one. That is what I have been working on this topic long time. In fact, IFS is going to bring out a guidelines for poor awareness reserve. That is in the pipeline. We are going to bring out a guideline, national guideline. And maybe we'll ask Dr. Papa to give her input on this guideline also. We'll send her.
Sir. Thank you, sir.
Again, congratulations to all the 3 chapters who are joined together. And please go ahead with the webinar.
Thank you so much, sir.
Thank you, sir.
Survin ma'am is not able to join, but she has sent us warm greetings for this webinar. So without ado, we're going to start with the first talk. To chair this session I request Dr. Revati ma'am.
Revati madam is not there, so you are Shanti Rani.
Okay, so Dr. Shanti Rani will be chairing this session on a talk by Dr. Rajapriya ma'am. Shanti ma'am is a professor HOD in Theni Medical College, and she is president of Obs and Gynae Society of Theni. She is a South Zone coordinator for various medical disorders of pregnancy, committee of the Foxy, and she has been awarded the best doctor by IMA and the best service provider award for PPI institute and lab sterilization. Her special interest is high risk obstetrics. Over to you, ma'am.
Thank you, Chitra ma'am, for the nice introduction. Outset, I thank this IFS South Tamil Nadu and IFS Pondicherry chapter for inviting me and giving this opportunity to chat this session along with Revati Janaira ma'am. Unfortunately, madam couldn't join, it seems. And I'd like to introduce now the speaker, Dr. Rajapriya Ayappan. She's the managing director of Srinivas Priya Hospital, Perambur, and she's an executive committee member of FPSI and OXY and ATN RCOG. And she's a committee member, endometriosis committee member in Foxy, and she's the secretary of Perambur IMA Women's Wing and secretary of IFS Tamil Nadu chapter. And her topic is premarital counseling. Over to you, madam. Madam, please unmute yourself. Rajapriya ma'am.
I still remember how beautifully Shanti ma'am had dressed up as Ponniyin Selvan character Nandini.
Thank you, madam. Thank you so much. Always be remembered as Kundavai rather than Shanti.
Yeah.
Thank you.
Yeah,
Thank you, madam.
You're such a sport. That's what I want to say.
Thank you. Thank you. Really honored.
Yeah. Thank you so much to Pondicherry for having including me as part of this beautiful webinar. So I think we have to look forward in future practice to incorporate premarital counseling as an important key, even basic gynecologist practice when we are addressing the fertility factor. Keeping that in mind, who needs premarital counseling? Ideally, all couples who are planning to get married, but particularly it is important when we foresee a relationship problem, sexual anxieties, if it's a second marriage or a remarriage, when there are pre-existing mental health issues or pre-existing reproductive compromise. I think we have to look at it that way. And when should it actually happen? When will you time premarital counseling? Before you start groom searching, or before or after the engagement, or is it after a failed marriage? And who is the right person to be offering premarital counseling? It is the gynecologist, a counselor, a psychologist, or a social worker. Now, what is the objective? Why premarital counseling in the first place? We have to understand that when a couple get together, particularly a gynecologist gets the opportunity to interact with a female person, the girl will be having certain personal habits. Particularly, we have to educate her about body odor and pubic and perineal hygiene. She may be having certain hobbies, maybe singing, dancing, or she may want to pursue it after marriage. She may have some professional goals kept in mind, particularly academic achievements. And she has to understand when marriage happens, she has certain responsibilities towards the partner. So too, the male has some responsibilities towards the female partner as well. So keeping fit is very important. We see a lot of overweight women these days. To educate them about body mass index is important. And they have to understand that once marriage happens, sexual life gets active. And then the legal implications of a marriage, that it is a contract between the husband and wife. Then the social role. Some amount of adjustment has to happen with the extended family. It may be a joint family or nuclear family, but she has to understand that things change. A new family is getting absorbed, or she gets absorbed into a new family. Indian weddings are always big, fat, costly weddings. And the whole basis for it in the traditional wedding is the horoscope matching. And the gala wedding is to celebrate the reproductive union of the husband and wife. But what is happening today? What is the status of love today? Do couples really connect? We actually don't have a formal pre-wedding preparation to help this newly married couple to face the real-time concerns and challenges post-marriage. So what is marriage per se? India is a country which is so diverse in its culture, language, religion, and the ways of life. And today, with more and more love marriages happening, there may be a Hindu and a Christian connecting, different castes and communities coming together. But at the end of the day, marriage is seen as a divine institution if it is proudly arranged by the parents, the so-called arranged marriage. And there, the couple come who they think are the right couples to form. But things are changing. And as we are moving towards the next century, we will have to understand to make an arranged marriage is going to be a huge challenge. And we have to see what is the place of premarital counseling. Probably when we look for the event manager to set the wedding stage, the decorations, the flowers, the invitations, we also have to look at probably premarital counseling is also an important aspect to keep this institution of marriage alive. Now, a goal of marriage is compatibility between the two partners, or is it procreation? And all these years, we as Indians were taught that it is a successful partnership into eternity, that is marriage. So from the traditional horoscope, let's move on to the new aspect of the medical horoscope. What does the medical horoscope look at in the couple? It's a review of the medical and family history, particularly a search for hereditary diseases, identify chronic ailments, particularly lifestyle diseases, or focus on pelvic and genital surgery, history of psychiatric or medical disorders which can affect the future lifespan of the individual, providing necessary vaccines, providing nutritional guidance. They may be overweight or underweight, or they may be having anemia. It's important for us to guide them, vegetarian, non-vegetarian, extra. Offering sex education and family planning advice is an important point from the gynecologist orientation. When we look at fertility, the fertility potential of the couple, doing relevant blood check, semen analysis, and a scan is important. Now let's look at the chronic diseases, how to screen and optimize them. See, if it is an autoimmune disease, there may be exacerbations and remissions. We have to see whether it's optimized control. Diseases like endometriosis and polycystic ovaries have to be controlled, and there are certain diseases where we screen for. Lifestyle modification is something which is key to conception, and that education has to be given. A search for heart disease, renal disease, whether it is in control, pulmonary disease, or epilepsy, where they may be taking certain medications. So what are all the medications they're already taking? That may be irritable bowel syndrome, etc. Sometimes they may be taking certain medications which is not conducive to plan a pregnancy. And these days, in the era of cosmetology, men may be taking some medications for balding or hair fall, which will not allow a pregnancy to be planned. Even for acne, if they're taking retinoic acid, that advice has to be given. So a knowledge of avoiding teratogenic drugs is key. And illnesses and medications affecting both the partners, we have to look into it. There are certain pre-existing issues affecting fertility. For instance, in the woman, it may be polycystic ovaries or endometriosis. In men, it may be undescended testes, or maybe for a testicular torsion, they were operated. So we look into the genital surgery, inguinal hernia operation, where the vascular supply to the testis may be affected. Pelvic surgeries, maybe there was a hydrosalpinx torsion which was removed. So these may not be of importance if the surgery had happened in their teens, but it becomes of key importance when they are becoming a couple. I recently had the opportunity to see a man who was just married 4 months. He was working in the Middle East and he had a unilateral scrotal swelling, which he assumed was due to the temperature conditions in the Middle East. Post-marriage, it was identified as a huge germ cell tumor for which he went an orchidectomy. And prior to that, he was identified as azoospermia. The wife immediately left him. He was just married 4 months. So I think it is important for men and women to go through premarital counseling so they understand their body and they understand where they stand in certain aspects of key medical and surgical problems. So reproductive potential is again important. We have a beautiful topic that a poor ovarian reserve is setting in a young age. So if a woman is not getting a proper menstrual cycle or a good flow, she may be having a low AMH and a poor reserve. So understanding the reproductive potential is so important because Indian marriages happen with the key motive that a baby should happen in the house within a year of marriage. And this is never the desire of the couple. It is the desire of a whole clan behind the girl and behind the man. So to satisfy this particular desire of the family and society and not to make them feel that the marriage has failed, reproductive potential assessment is important for those families where marriage focus is reproduction. Let's look at sexual health concerns. They may be having certain sexually transmitted infections or pelvic infections. Today, there is a word called LGBTQ, which is all over the media, which stands for lesbian, gay, bisexual, transgender, and queers. And we as gynecologists with focus on infertility practice should know that sexuality and attitudes are so important to make a successful marriage. Again, I would like to quote a recent couple where I met. They are married 1.5 years, and trust me, the girl has taken a prayer that she will not indulge in intercourse for 1.5 years as a prayer. This is an arranged marriage, and the man has accepted on divine grounds that he will not touch her till 1.5 years. They came to me for counseling, and the girl says, we are planning marriage, we are planning to go ahead from next month. I would just like to say, I'm afraid of pregnancy and childbirth. So you really wonder whether it is for the prayer she wanted to avoid intercourse or whether for fear of pregnancy. So these sensitive sexual health concerns have to be addressed. Now, I already mentioned about long-term medications which can affect fertility or which can cause teratogenicity. Mental health is again something very important. We do have stress playing a role in today's young. Their acceptance to failure is very poor. So this can lead to low-grade mood disturbances, hysterical behavior. We have to keep that in mind. Now, this is routine where we screen for certain infections and offer vaccines for hepatitis B. Rubella vaccine is particularly important if it is a woman. And these to be updated along with the HPV vaccine, which we give for prevention of cervical cancer. Looking at familial disease, we already mentioned the screening for hereditary disease and giving proper advice, especially if they are planning marriage within family. Screening for carrier is so important with respect to thalassemia and Duchenne's muscular dystrophy. and appropriate genetic counseling has to be given. Now let's go back to psychosexual health, psychosocial health. Mental health balance is so important. So they learn to cope up with each other, and adjustability is today such a big problem. Within the family, we see with a tussle with our own children, and sometimes we wonder how will they handle the institution of marriage in future. So it is important for them to understand a little bit of give and take policy is important. We already discussed about the gametotoxic and teratogenic drugs. Coming to habits, a good lot of women today indulge in smoking and regular alcohol intake. It is no longer social alcohol. So it's important for us to understand that Indian women abstaining from tobacco or alcohol is not happening, but sense and sensibility of advice has to be given that when they are planning pregnancy, certain habits have to be given up, and so too drug dependence with respect to easy access to illicit drugs. Now, what about relationship problem? Yes, we already said that this is an extended family. The girl not only has to get along with the husband, but also with the husband's family. A new lifestyle might start for her. She may be a vegetarian, they may be non-vegetarians. So simple day-to-day life challenges will be there. But when a couple fall in love with each other, then all this adjustability automatically comes in. But if they're going to have a previous relationship problem, they had already had a love affair or they were physically intimate and that relationship had got broken, they may have some guilt. Sometimes there may be a premarital pregnancy as well. And they're planning a marriage where they want to hide that particular factor. They may need a counselor if they're going through certain problems. And this is an absolute new responsibility. You're signing up to be part of another person's life. And the whole idea is to bring happiness to each other. And that should be the focus. Similarly, today's young are not ready for a baby soon after. Sometimes they may want to plan a pregnancy. So allowing a pregnancy to happen and then the couple coming and saying, I don't want this baby because I have an exam coming up, I'm going in for termination, is a totally unplanned pregnancy and unnecessary abortions. We have to really speak forth on this regard and help the woman plan her pregnancy, and so too spaced pregnancy. Sometimes the spacing just doesn't happen. By the time one kid is hardly a year old, the second kid comes in. So telling them that there's something called a contraceptive and the right age to have the child, all this education, not wait till they are 35, allow the ovarian reserve to fall and then plan the baby. So all these key aspects can be discussed in premarital counseling. And with this movement of DHERA, violence against women and coerced sex, gender-based violence, all these are important. Sometimes women don't even know that they are getting abused when it's an early marriage happening. And these beautiful things, the right opportunity is premarital counseling. End of the day, let's get into our subject. We all are passionately practicing infertility. Sex education is key. Masters Johnson's model is there, the 4 stages of sexual act. And ultimately for a husband and wife to be able to have the sexual act which gives pleasure and happiness and keeps their health platform in the right zone, chemistry must work. That's so important. And sometimes certain couples just can't get along, especially men. If they are put into the first night pressure or the performance pressure, it can be a disaster. The woman may just feel that she's not married the right guy. I still remember a particular couple who came to me within a week of marriage. They were about to board a flight to go to the USA. And that girl from Chennai, the guy was from Bangalore. The girl was so upset. How do I marry this guy and go to USA? We've not yet had our consummation of marriage. What if this fellow is not able to perform after going there? So doctor, give some drug. We are traveling on Saturday and that was a Thursday. And she said, it has to happen before we board the flight. Trust me, is there that kind of a tablet available? Only my chairperson should say. So it's a very big challenge if someone is breaking the ego of the boy and expecting performance to happen at the command of the wife. So when Google or various romance gurus start educating our young, that's not the right platform. You need to have scientific, authentic, realistic information so that their sexual life kicks off on the right platform and those magical moments stay in their mind forever. And of course, some education on aphrodisiac and pheromones and sex toys is also important. For that, We need to be able to talk about sex very comfortably with a couple. We ourselves should not see it as a stigma. We should not hesitate to talk to them. And we should give them the room so that they can share their concerns of intimacy. It is not very easy for someone to talk to us about their bedroom problems or fears. So if we give the room, the woman will come out with her sexual fears. Someone could have planted a thought that on first night, she will tear her hymen and there will be blood splattering everywhere. There will be severe pain that she cannot walk for a week. Now that is something which she might have in her mind, and she may avoid intercourse. And sometimes what starts off with weeks can become even months and years, non-consummation of marriage. So a female can be a passive partner in a sexual act, but she can wreak havoc in the life of an active sexual partner. So it's important. A painful intercourse in the female can lead to secondary erectile dysfunction. We have to address their anxieties. Sometimes the male may feel he has erectile dysfunction, or the female might have some preconceived female sexual dysfunction, which can be discussed as what is the experience, the inhibition, the lack of knowledge, and then put together and educating the woman. Yes, initially sex can be painful, but the vagina will loosen up with good lubrication, and a proper foreplay or stimulation can help her to enjoy the sexual experience better. And so too for the male. It may take some time to learn the art of the sexual act, and with practice makes perfect. That is something we have to educate them. And also tell them that communicating with each other what they enjoy or what they do not enjoy is important to have a healthy sexual experience. And that's completely what the couple's preference is key, not a particular book or a particular internet dictating what they should be doing on bed. And we also have to tell them that non-sexual forms of sexuality is also there, like kissing, touching, massaging, cuddling. That's called extercourse. So it doesn't mean that romance is only intercourse, and intercourse is no urgency in a newly married couple's life. Now, divorce rates are skyrocketing. And if we are not intervening in bringing the connection properly between the husband and wife, it's a smartphone era. Each one has their own gadgets, and the time spent with the gadgets versus with the partner, if you see, it is only the gadget which will win, right? So we have to make it a key point that they're career oriented, they are less committed to each other, and they're more committed to taking selfies and posting on social media. So the self-centered attitude should be broken. And psychosexual counseling, we have to say that love is not essentially just in the heart. It is something which starts in the mind as well. So we have to bring a good connection between the mind, body, and soul, and understand that the heart and brain have to get connected to be able to express their love for each other in the sexual form. So I would like to conclude on the note saying that as gynecologists, whenever we get an opportunity, we have a lot of patients who come and tell us, my marriage date and my period date is coinciding, doctor. So give me some medication to postpone my period and things like that. So every opportunity, we might have done a chocolate cyst, we might have done a torsion ovarian cyst surgery, maybe a very bad polycystic ovaries with only induced period. Grab the opportunity, offer premarital counseling, tell them they have to take preconceptional folate, address fertility potential whenever it is essential, educate them that they don't have to worry about timed intercourse within the first year or second year of marriage. Have sex whenever you have the time, mood, or energy. No gynecologist or fertility consultant should dictate terms inside their bedroom. No scheduled sex, because it can affect the natural flow of their sexual activity. Give them contraceptive advice so they can plan their pregnancy. Avoid termination of an unplanned pregnancy, and tell them that unnecessary interventions can lead to subtle pelvic infection and possibly a subfertility. So on this note, premarital counseling is our duty towards our young couples, and marriage is all about compatibility. And we have to put our experience there and talk to them in a language they can understand, give them a lot of time, so that we make Indian marriages continue to work the way it was working. At the same time, we stand for women's empowerment. The woman is a multitasking person. She can have a beautiful work-life balance, and she can be a successful wife and a mother. That is also something we will put our women down. We will understand that we will keep them empowered, and we will make many more couples have a great marriage and make sure that premarital counseling and fertility potential and the right advice to avoid abortions should be the way forward. So thank you so much to IFS for having given me this opportunity to voice on premarital counseling.
Thank you, madam. Thank you, Rajapriya, madam. Actually, myself really much interested in to listen to you. What is your talk really going to be? Because premarital counseling is most of the counselor will be doing. And regarding this financial status, most of the couple after getting married only, either it is a love marriage for long years or it is an arranged marriage. After marriage only, they find themselves that they are not fitting in the same page. So most of the couple are coming in the crisis time only. At the time, they are not in a mood to listen to us because already the damage has happened. So it is a little difficult to convince them. So the rate of divorce, as usual, it's skyrocketing. So really, your talk is an eye-opener, and you just approach in a gynecologic perspective of this premarital counseling. Really, very understandable and useful, hopefully, for all gynecologists, for us, how to counsel a couple even before marriage. Thank you. Thank you so much.
Thank you so much.
Can I ask a question, Rajapriya?
I would love to, Dasri. Good evening.
Yeah, it is a very fantastic deliberation. I'm just feeling that I'm just sitting in your clinic. So nice presentation. But we do get sometimes, I had an occasion when one of my distant relatives saw a girl for her son. And she sent her because she had irregular cycles. So she sent her to me to do a scan, So there was a small unilacular cyst of 6 centimeters. We did explain that this can be corrected. So what is your take on this? How exactly now the counseling has to be given to this would be mother-in-law. So how do you deal this problem? Does it really, impact, make a difference in taking this girl as her daughter-in-law?
Yeah.
And what are the repercussions in this kind of, previously we used to check blood sugar, blood RH type.
Yeah.
Nowadays, because of this PCOS problems, irregular cycles, how exactly we can handle this?
If we had the opportunity to treat them, as I was rightly saying, most of these girls, when we are operating or we are treating, I always sensitize them saying, once you're starting to look forward for a proposal, you need to come and meet me because we have to more aggressively work on it for 6 months on lifestyle, set targets to lose weight, ensure that at least she gets it once in 40 to 45 days. But if it is a surgery, say I have done a dermoid cyst. I just had a recent young woman who had done a dermoid cyst. She had done that 2-3 years ago. Now she is planning a baby. So she wants her mother to tell when they are seeing the alliance itself that I had a surgery because she has a laparoscopic scar. The mother was saying, if I'm going to say my daughter had a surgery, how will the proposals work? So what I told was, you don't have to tell every person that my daughter had a surgery. You go ahead, you see your routine horoscope, see if both families are happy with each other. Once you're 100% sure that both the families are extremely happy, the boy and girl have met and they all feel everything has worked out, at that moment, you can decide to open up to the particular, because these days they go for dating, ma'am, once they like each other. Just open up and tell, I had a surgery, but if the AMH, everything is good, you don't have to worry. You bring that partner to me. We will do a counseling and tell him, yes, she had a problem, but we have fixed it. Things are good. I have the latest scan report. You, instead of falling for a girl whose health status you don't know, you're falling for a girl whose health status you know. So I think as gynecologists, we stand for the fertility potential of the concerned girl. Give them the confidence, go for it.
Thank you for the medical horoscope. So nice.
Rajapriya, see, I will share my experience. Like one of my patients with a history of primary amenorrhea at the age of 16 plus, she came to me. I diagnosed her as a case of Kallmann syndrome. Okay, hypo with anosmia. So then as usual, she was from a lower socioeconomic group, from agriculture-based family. So I told that girl that it's not an issue. You have enough of X, but only thing is it is not coming up in a proper time. So then I gave her withdrawal bleeding. Everything was all right. Then once when she planned marriage, she came and told me, Madam, I'm going to get married. I told her, bring your husband. Okay. So then we counseled that husband, that we said that she's she is slightly deficient in her hormonal status. For example, like a thyroid patient where we supplement thyroid, he is having a deficiency of this gonadotropin. So then they agreed. Then promptly they came for treatment, stimulated, and then she had a very beautiful baby. Then after 2 years, again she came back and she wanted to have the another baby. See, the simple thing she told me was, Madam, pana enna irukku, oru kaal kaani nilatha vittana, and the panatha kondu I will have a baby, madam. So, and likewise, this endometriosis patients also, we have to counsel them a lot. Especially now we see a lot of adolescent endometriosis, and my advice is not to touch them surgically. Treat them as far as possible with the medical management. And if they get married and if they are not conceiving in spite of all our advice, maybe that is the stage where we need to go for surgery, because straight away going to ART is also a difficult thing because spending money. But instead, all of us note that surgical management of endometriosis in early stages and even in endometriomas can give a spontaneous or like ovulation induction. Pregnancies can happen up to 60 to 70%. Only the few percentage of them may need an IVF. So that is also, so based on each disease, like I won't rather say it as a disease, problem they face, we have to counsel them. And if we counsel them in a proper way, I am sure that they will get benefited.
Yeah, that's why
vaccination, rubella vaccine and Gardasil, never forget in preconceptional counseling. That is also a must.
That's why I feel, ma'am, gynecologists have a big role to pull them up and give this appropriate advice of controlling a problem and then not putting across to that family. Yes, this girl can have marriage and have a successful family life.
Yes.
Thank you, ma'am.
Thank you.
Thank you, ma'am, for this wonderful discussion. Thanks, the chairperson and the speaker. Now we are going on to the next topic, which will be given by Dr. Dasi Papa on poor Orient Reserve. And to chair this session, we like to welcome Dr. Uma Velmurugan. She has did her graduation from Stanley Medical College, and presently she is managing director and chief consultant at Venus Fertility Center. She is a renowned gynecologist in Tirchi since has experience of 25 years and consultant at Apollo Hospital. She is a member, joint secretary, organizing chairpersons of annual fertility CME in Tirchi, and she has also completed RCG training in advanced training modules. So one more chairperson for this session is Dr. Nirmala Vijay Kumar. She is consultant on Queen's Fertility Center. Currently, she is a secretary of Foxy Tirunelveli, vice president of IMA, secretary of SPCA Tirunelveli, and co-convener Friends of Heritage Sites. So I welcome both of you to chair the session for this topic on poor Orient Reserve. Over to you, please.
Oh, thank you, Chitra. Thank you so much for the warm welcome. So I will go ahead and introduce Dr. Papa Dasari, who is going to be the speaker on poor ovarian reserve. She is MBBS, VGO, MD, and also a fellowship in reproductive medicine, senior professor at DIPMA from 2002 to now. She has more than 109 publications in national and international journals to her credit and was the president of JSS from 2019 to 2020. She is the vice president of JSS, vice president of JFA, and head of WCH 2017 to 2020. What is WCH? Women Child Health. Is that a society in DIPMA?
I
don't know who has written this CV.
This is our hospital CV we are given. Yeah.
So yes,
actually, if you tell.
No,
Madam
I'm sorry. I don't need any introduction.
Yeah. Madam is having a lot of experience in teaching experience, and
fine. I don't know how Chitra has put this CV of mine. Where she got? Maybe
no. It's not put by mine. I don't know, madam. They have taken it.
I don't know. I don't know. This is.
I don't know.
I never gave you my CV. Forget about it.
Yeah.
Thank you, Dr. Nirmala Vijay Kumar, for nice introduction. So I would like to introduce myself in this forum as the founder secretary of IFS Pondicherry. Now I had handed over to Dr. Chitra, which she has arranged this meeting. Since 1 year, I have been trying to arrange a meeting with Dr. Rajapriya madam, but somehow it is not materialized because of lack of quorum. So this is a good opportunity combining IFS, Tamil Nadu and Puducherry, so that we can have a lot of interaction and we can gain a lot of experience. We can hear experience of a large audience. So my talk now is just going to be poor ovarian reserve, and Dr. Rajapriya has made my job so easy that fertility potential of the couple in premarital counseling. Maybe we have to include this the potential, one of the potential of the intact genital system and also the ovarian reserve. So can I share my screen?
Yes, ma'am.
Yeah, come on. Can you see it?
Yes,
Is it visible?
Yes, ma'am. Yeah, it's visible.
So my preparation for this talk is mainly on the etiology of poor ovarian reserve. I'm going to talk real basics. I mean, it wouldn't be like what Dr. Rajapriya has highlighted so much with so many examples. Just the real basics, etiology, why there is a poor ovarian reserve, as it was told by Dr. Ramani madam also, that many young people are coming with poor ovarian reserve. In fact, in JIPMER, we receive patients after going through multiple hospitals, and they just come mainly for the advice. And
Madam, make it as a slideshow, madam.
Yes.
Okay.
So the coming to the term ovarian reserve, as everybody knows, that it refers to the functional potential of the ovary, and it is said that the number and quality of the oocytes within it. So it includes the non-growing follicles, pre-antral follicles, antral follicles, which are capable of ovulation. What are the implications of?
Ma'am, sorry to
sorry
interrupt, ma'am.
Yes.
Your first slide only seen, ma'am. Your introduction slide only seen, ma'am. So can you please stop, share and share again, ma'am?
Stop share.
Yes, ma'am.
You are not able to see?
You can see, ma'am, but it is on the first
seen, ma'am.
slide only.
Okay, this is my first slide.
Yes.
But
yeah.
it is
Now?
not in the slideshow, ma'am.
Now?
No, ma'am, you
Still
need
the
to
same,
stop
ma'am.
share, ma'am.
Ma'am, kindly reshare it, ma'am.
Close down the PPT, then reshare, madam. Again, stop sharing that. Yes.
Yes, ma'am.
Now,
Well,
now
sharing, please click on the screen and then share, ma'am. Please don't click on the PPT. Click on the screen and share, ma'am.
Am I out of the? Just give me a little bit time. I call my son. And sorry, phone. Coach, what? I came out of the Zoom. It is not showing this head. The screen is not opening. Open. Please share.
Hi,
It's
Ramya, I have joined.
Yes, welcome, madam.
Yeah.
Yes,
Screen is
madam.
seen, ma'am. Go on to the
I am in Nagarkoil.
slideshow, ma'am.
Okay.
Okay. Nagarkoil,
Is it seen?
installation ceremony
Yeah,
வந்துட்டாங்க.
slide is seen, ma'am. Just go on
No?
the slideshow, ma'am.
Is it seen now?
Yes, seen, but still the same. Go on to the slideshow, madam.
Slideshow only. I'm in self.
No, you make
No,
it
no.
full screen.
Full screen.
Make
Full
it full
screen.
screen.
Full. I am seeing full screen, ma'am. Here.
No, madam.
No, not it.
See, you on the sides, you are seeing the slides. No, so you come down, or no. Once again, she has gone.
Ma'am, while sharing the screen, you need to click on the screen option, ma'am, and then share it, ma'am, so that it will be full screen.
Someone is sharing the screen. It is saying.
Yes, ma'am. Now you can share it, ma'am.
Can you see now?
Yes, ma'am.
Yes, ma'am.
Perfect.
Yes,
Good
ma'am.
now.
Yeah.
It's correct.
Okay. Thank you. Just this. So sorry for the interruption. It's not moving. Something
Ma'am,
happened.
please
with
click
this.
on the screen, ma'am. It will start moving.
So the implications of knowing a ovarian reserve is to predict the fertility, and sometimes we have to preserve the fertility in certain situations. And also when we recruit the oocyte donors, it is essential that we should know what is their ovarian reserve. And recent studies have shown that ovarian reserve plays a very great important role in general maintaining the general health of the woman and protecting from various metabolic disorders. And it is also a surrogate to know that when natural menopause is going to occur. So there are a lot of confusing terminologies like ovarian response and ovarian reserve, which sometimes it is been interchangeably used. ASRM 2020 is defined the ovarian response as actual oocyte yield when you do ovarian stimulation. And poor ovarian response is identified by a reduction in the follicular response to maximal stimulation, but it is not just on the ultrasound. Ultimately, you may see a lot of follicles, but you may get very few oocytes. So the poor ovarian reserve refers to decrease in the retrieved oocytes. And there are some standard criteria, especially many people are following Bologna criteria, which say that age more than 40 years and one normal ovarian reserve test, and also poor ovarian response, that is getting less than 3 oocytes. Two of the 3 should be present to say she has a good ovarian response. But in the absence of this, 2 episodes of poor ovarian response after maximal stimulation are sufficient to define a patient as a poor responder. So this in 2016, Poseidon criteria have come where they have taken the cutoff of age less than 35 years and more than 35 years, and serum AMH and AFC were used. AMH cutoff is less than 1.2 nanograms per ml, AFC less than 5. But still there are some schools of thought that even though AFC is 5, sometimes the AMH is higher. So there is still a lot of debate saying that what is poor ovarian reserve. So the other terminology is diminished ovarian reserve, that is a decrease in the number and the quality of the remaining eggs in the ovaries, and a poor response to ovarian stimulation. So And ASRM 2015 has described poor ovarian reserve as reproductive age women having regular menses and whose response to ovarian stimulation or fecundity reduced compared with women of comparable age. And recently ASRM and ACOG, the joint committee, has given some criteria, that is AMH cutoff less than 1 nanogram, FSH 10 international units, more than 10 international units per ml, and AFC less than or equal to 5 or less than 4 oocytes retrieved in an IVF cycle. So when can we suspect poor ovarian reserve clinically? There is a family history of premature menopause, or if the woman has got primary amenorrhea, absence of secondary sexual characteristics on examination, or there is a secondary amenorrhea, oligomenorrhea in a Paris woman, or a premature menopause, infertility, age more than 35 years, history of endometriosis, surgery, chemotherapy, and radiotherapy. And there is as I already said, there is a lot of confusion regarding the terminology. There are various articles in the literature, but whatever it is very important to acknowledge that decreased ovarian reserve and poor ovarian response are not interchangeable. If patient is diagnosed with decreased ovarian reserve based on ovarian reserve testing, it does not signify that she will have poor ovarian response during her stimulation. When properly assigned, it should be signified that a patient is at increased risk of poor ovarian response and may indicate higher starting dose of gonadotropins for ART when compared to a similar woman whose age is 35 or less. So what is the incidence of decreased ovarian reserve? When the Bologna criteria was used, people have reported as high as 26% incidence of decreased ovarian reserve. And it is reported by various studies, 10% of all women undergoing ART cycles have decreased ovarian reserve. This is one of the studies where in young women of less than 35 years of age, the incidence of decreased ovarian reserve is reported as high as 50% when the cutoff of AMH less than 1 nanogram is taken. This is the one study which we did in JIPMA. When we classified the ovarian reserve, as for Umar Singh et al., the article published in 2020, into normal, low, and severely low. You can see here about 32.5% had low ovarian reserve by AMH, and severely low, that is less than 0.3, 7.3% had that. So to predict the response, or to say the woman has low ovarian reserve, whether we should take AMH or AFC. So in this study, we have done a Spearman correlation coefficients test. There is a good correlation for predicting normal ovarian reserve when AMH and AFC are considered, but for poor ovarian reserve, the AFC, the correlation between AMH and AFC are not significant. As I already said, a woman may have 10 AFC, but her AMH may be low. So, so it is not correlating. So the significance of this is that we cannot forego doing AMH, and one cannot start a stimulation based on AFC alone, as some people are, because to reduce the cost, they are just starting just by measuring AFC. So these are various ovarian reserve tests that are there. Clinically, age and menstrual cycle regularity, biochemical tests, which we have. The most important one is the AMH, and ultrasonic, the most important one is the AFC. Dynamic tests nowadays only for research purpose, we are not really doing them. So the ASRM committee opinion in 2020 says that currently AMH and AFC are the most sensitive markers, but the ability of AMH and AFC to predict oocyte yield as well as poor and excessive ovarian responsiveness has been well demonstrated. And poor ovarian response to maximal stimulation during IVF reflects, if it reflects decreased ovarian reserve, no further ovarian reserve testing is further ovarian testing reserve is unnecessary. So extremely low AMH values also should not be used to refuse treatment in IVF. This is the ASRM committee opinion latest. So again, coming to the causes of poor ovarian reserve, which I have already put a slide, it may look same. That is the whether we can clinically suspect ovarian reserve. So these are the other causes. Most important causes which may not be able to diagnose are the genetic factors, premature ovarian failure, and systemic disorders. Many medical disorders like autoimmune disorders like SLE, scleroderma, hypothyroidism, diabetes, and endometriosis, tuberculosis, chronic pelvic inflammatory disease, fibroid uterus, adenomyosis, and anti-cancer treatments such as chemotherapy, ovarian surgery to remove cysts, teratomas, and unhealthy lifestyle habits. This is coming up in a big way. There are a lot of studies where stress, obesity, and anorexia, and all smoking, etc., and environmental pollution. All these factors can result in poor ovarian reserve. And another iatrogenic factor is that repeated ovulation induction. As I have already mentioned, these women go to different centers and undergo many cycles of ovulation induction, and by the time they land up to a proper center, proper a fertility specialist, they may not see a fertility specialist in the beginning, and already their ovarian reserve would have suffered. We will see about few studies addressing on this aspect, whether repeated ovulation induction causes poor ovarian reserve. So these are the causes of premature ovarian insufficiency. I just want to skip this. And because of premature ovarian failure, the general health of the woman is affected, like premature menopause. They have a lot of symptoms, and also long-term sequelae, cognitive impairment, accelerated cardiovascular disease, autoimmune disorders, and adrenal and thyroid problems, osteoporosis, and also they are at high risk of death. So this calls for screening women for ovarian reserve and then protecting their reserve to maintain the general health of the woman. To know this, exactly how this poor ovarian reserve and at what stages of development in the infancy, childhood, fetal stage, or adult life, it is important to know the ovarian development. During fetal life, the development of ovary has 4 stages. One is the indifferent gonad, stage of differentiation, and period of oogonal multiplication, and the stage of follicle formation. So we know that the indifferent gonad stage has 3 sources. The ovary develops from the genital ridge as early as 4 to 6 weeks, and from the coelomic epithelium, which follicular cells form, and primordial germ cells, or from the endoderm. They are there in the yolk sac. They migrate here and they go into the genital ridge. And then there is formation of these genetic sex cards, and this gets transformed into the ovary by various mechanisms. So when we see under the ultrasound, a pregnant woman coming to us at 4 to 5 weeks, this fetus, which is going to develop into the fetus, is already formed. This process is initiated, that is formation of the ovary. And when the yolk sac is clearly seen, that means the ovary formation has already occurred. So in the future slides, which I am going to show, the intrauterine environment at this time, whether the mother is consuming some drugs or she's taking a good nutrition, is very important, because it is at this stage the genetic causes can come into play, and ovarian reserve of the upcoming fetus can get affected if it is a female. So all of us are aware how an XX individual is going to develop, that is in the absence of SRY and activation of the genes associated with the female pathway. The three genes that are important are the VNT4, RSPO1 and FOXL2, and these are very much essential for the development of the ovary. So if there are any mutations in these genes because of the nutrients or some drugs that mother is taking at the periconceptional period or preconceptional period, there is going to be low reserve at birth. The indifferent gonad stage will go into follicular growth, where these cells, endodermal cells, will get into the somatic cells and they form the genetic sex cords. In this process, the key player is the AMH and also TGF beta family. It is expressed GDF in the granulosa cells after formation of the primordial follicles, and this is going to affect up to antral follicle stage. So this is to show that various genes that are responsible at the development of the ovary, and all of us are aware that all the genes are going to act and the follicular pool is going to be finally determined at birth is going to be only 1 lakh follicles. This is because of the pro-apoptic factors like BAX and BCL2 associated X protein and apoptic factors. And there's what is called the notch signaling, which determines the interaction between the oocytes and the granulosa cells and determines whether these cells, oocytes, can survive or not. And if any of these genes are knocked out, like Notch2 is knocked out, it leads to decreased germ cell apoptosis and also the formation of multi-oocyte follicles. Sometimes we call it as a PCOS. So PCOS with not high AMH, even we have seen there are some cases of PCOS where the AMH is normal or very low. This explains where the genetic problem lies. So this follicular pool is also maintained by two genes called BMP15 and GDF9. So when they are heterozygous, there is going to be premature ovarian insufficiency, and especially BMP15 mutation can cause ovarian dysgenesis. And at the primordial follicle growth, activation of FOXO3A induces infertility because it blocks the primordial follicular growth. So when we see the fetus like this at anti-scan, that means this fetus is, if it is a female, the meiosis initiation has already occurred, and this is due to stroite gene upregulated, which is in which retinoic acid is very much essential for humans. I skip this. So what is happening? This graph, everybody is aware that at birth there is going to be 1 lakh follicles, oocytes, and they get maximum in the fetal stage, then they gradually decrease, and at 30 years, 30 to 40 years, the decrease in age-related decrease in ovarian reserve is going to occur. Finally, at menopause, some thousands oocytes are there which are of poor quality. So this is very important in our counseling, and the best age to have childbearing is said to be between 20 and 30 years, where their ovarian reserve is optimum. So this is a study, review of the study of ovarian reserve in young women. You can see here there is a 50%. I don't know, I'm sorry, I think I've repeated this slide. This et al. Has found that recently in 2019, the incidence of poor ovarian reserve is as high as 50% in women under 35 years of age. Ovarian aging and general health. So ovary is supposed to be considered as the pacemaker of female body aging, and multiple organs are affected if the ovarian reserve is affected. It is the earliest staging organ, and the occurrence and development of the disease lead to decrease of the life quality. Because of the development of a variety of diseases, they are more prone. Women with decreased ovarian reserve are more prone to develop diabetes, cardiovascular disease, and obesity. Maybe it is a vicious cycle. And it is said that a woman ovulates only 500 times in her lifetime, and 99% of these follicles are wasted. And estrogen secretion decreases with decline of the ovarian function, and this leads to multiple organ dysfunction. And this is in line with the DOHAD, that is where we have learned that intrauterine growth restriction and developmental origins of the health and disease. And this is a link between intrauterine nutrition and the development of ovarian reserve. It is being proved in sheep and other animals that the intrauterine environment when the ovary is being developed is very, very important. And this is also studied in young women where small for gestational age babies are there. They have reduced ovarian volume and increased FSH. And there are other studies where how this development of PCOS and associated effects on ovarian reserve have come into play. In sheep, there is an evidence that exposure to androgens, excess androgens, can develop later into PCOS. And we know a lot about the endocrine disruptors, and they act on these estrogen receptors as estrogens, and then they can also act on the as aryl hydrocarbon receptors, and then especially binding to the dioxin. They reduce the and bring about atresia of some of the follicles also. Treatment with bisphenol A. It is being found that there is a changing in the balance of anti-apoptic and apoptic factors, which they affect and then bring about the apoptosis and cause follicular atresia, and also the maturity of the oocytes will be affected by accelerating the follicular atresia. These are some of the studies to show that how BPA is bringing about meiotic abnormalities in oocytes and causing decreased ovarian reserve. Smoking, which has become very, very common nowadays. How does it affect, how does it bring about decrease in ovarian reserve? Because it will affect both the somatic cells as well as the oocytes. It decreases the increases the soluble vascular endothelial growth receptor and causes decreased angiogenesis and decreases the oocyte maturation. If the maternal smoking causes this at the developmental stage. So to summarize the environmental factors, so both a prenatal exposure and adult exposure of environmental factors like economic factors and some of the other factors through nutrition, they affect the nutrition, and then they cause damage at the prenatal development of the ovary. And the androgens also act in the developmental stage. Cigarette smoking, maternal cigarette smoking, or a second hand smoke also can affect and decrease this ovarian reserve in adults. Obesity and ovarian reserve, there are many studies. Balkan and colleagues, they have published a study in 67 women with metabolic syndrome. And Steiner also, they have done a randomized control study in non-obese and obese women and found that the mean AMH is definitely lesser in obese women whose BMI is more than 30. And other diseases, tuberculosis, chronic PID, endometriosis, type 1 DM, type 2 DM, These are the effects. Tuberculosis affects by cell-mediated immunity and also produces fibrosis. And chronic BID also produces the fibrosis in the ovarian cortex. And there are few studies where they have found that decreased AMH in women with chronic PID. And in type 1 DM, the autoimmune mechanisms cause atresia. Type 2 DM, PCOS is more common. We have seen many PCOS women coming with type 2 DM, and because of the suppression of the recruitment of oocytes and also hypovascularization, this will lead to atresia, and this will cause follicular atresia and decreased ovarian reserve. And hypothyroidism causes premature ovarian insufficiency. The incidence especially is increasing because we get patients, every other patient in our OPD is subclinical hypothyroidism. And hyperthyroidism also causes, because it causes a decrease in concentration of available gonadotrophins for follicular recruitment and growth, and ultimately premature follicular atresia. Fibroid uterus and fallopian tube pathology. There are few studies where there is a decrease in AMH levels after myomectomy. So we have to counsel the patient like how we counsel for endometriosis. When you undertake myomectomy, that there is a chance that there is going to be decreased ovarian reserve. This is by altering the blood supply to the through the mesosalpinx to the ovary. Exertion of early follicles. What is the mechanism? Because of the ROS in the follicle oocytes, repeated ovulation and induction, it will lead to microtrauma in the surface of the ovary and also corpus luteal cells. This is especially reported in ART cycles. And antioxidants enzymes that cause repair of these ROS are reduced. And this is the reason, even if a lot of follicles develop and oocytes are not of good quality, so there is no way that we measure the quality of the oocytes except that we can grade. But this explains the reason that ROS in the oocytes is the reason for failure of fertilization or implantation. So this short review has told that conflicting results. They said if only 3 cycles of ovulation inductions are given, there it may not affect. But if 6 cycles or more than 3 cycles of ovulation, repeated ovulation induction, there is a definite decline with repeated cycles. Both pregnancy and live birth rate also was decreased. So we did a study in JIPMER a decade ago. This was a thesis of Dr. Karthika. We had 3 research questions. One among them was whether repeated ovulation induction decreases ovarian reserve. And this is, we have studied 3 cycles with 50, 100 and 150 milligrams of clomiphene citrate. That time clomiphene citrate we were using, not letrozole. So there is a decrease in the ovarian reserve with 150 in the 3rd cycle, but response is good. Here we recruited the people when there is no history of prior ovulation induction. So even with the 3rd cycle, there is a significant decrease. Here you can see 0.05 in the 3rd cycle, that there is a decreased ovarian reserve. So this has to be clarified with the large studies. The sample size here is very less. And in the recent study also we have done between the poor responders, women with poor ovarian reserve and normal ovarian reserve, we compared that after 3 cycles and they received controlled ovarian hyperstimulation for ART, there is a significant decrease. The p-value is 0.001. So this also needs to be confirmed by large studies. So in this study, we did a logistic regression analysis, because here all the women are less than 35 years of age. And the significant factors are age more than 30 years, endometrioma, which is already established factor, and prior history of ovulation induction of more than 3 cycles, and hypothyroidism. They are significantly associated with poor ovarian reserve. So the mechanism is that whatever is the insult, there is a increased ROS, and expression and activity of oxidative defense system is reduced, and there is oxidative damage to the cell membrane of the oocyte, and protein oxidation, inactivation of the enzymes, and DNA damage, and increased apoptosis. Again, all these are under control of the genetic expression again, so it is a complex mechanism. This was proved that there is a higher ROS levels in unfertilized eggs or formation of low quality embryos. So how do you prevent ovarian aging, quality and quantity? Nowadays, a lot of medical reps are coming with all these antioxidants, combining with inositol, and combining with clomiphene citrate, and combining with letrozole. So there are a lot of studies where this vitamin E, vitamin C have been given for a time of 3 to 6 months, that they reduce the oxidative stress and improve the quality of the oocytes by correcting the chromosomal aberrations in the metaphase 2, simply to say that. And you know that Vovashield, NAC, and acetylcysteine, we have seen by experience that you know the pregnancy rates are high. I don't have the data. DHES, yes, again we are using more and more this DHES in women with low ovarian reserve, and the results, we have seen few patients where the ovarian reserve as measured by AMH is improved to a certain extent. Like when the ovarian reserve AMH is less than 1 nanogram per ml, when we give this drug for 3 months or 6 months, there is a increase in AMH. We have seen up to 3 nanograms per ml. So this one graph that shows that in decreased ovarian reserve patients, that there is an improvement in AMH after giving DHAS for a minimum of 3 months. So the recommendation by the Center for Human Reproduction 2014 on this nutritional supplementation. Actually, DHAS is called nutritional supplementation. The indications are diminished ovarian reserve, ovarian aging, and attempting to improve chances with ART, the quality, and reduction of aneuploidy of embryos, and it will also reduce miscarriage rates. So this article, I think all of us should read it. This anti-ovarian aging pharmacological strategies would affect at the molecular levels. All these, some of you must have used this NAC, melatonin, rifamycin, especially, and nutritional calorie restriction by metformin and tamoxifen, and also the use of hormones, leptin, DHEA. All this, I'm sure each one of us must have used sometime or the other. These also act as anti-ovarian aging drugs, and improve the ovarian reserve, and also correct the chromosomal abnormalities. And this article I want to share with you: can ovarian aging be delayed by pharmacological strategies? Kindly go through it. Because of the time restriction, I have not put other data in the article, from the article. So to summarize, poor ovarian reserve is becoming more and more common in young women. We have to screen for the risk factors, historical risk factors, and also on clinical examination. And the etiology of poor ovarian reserve is diverse. So proper history taking, examination, even screening for affordable patients by a biochemical test, that is by AMH. Even though people will say only you are supposed to do AMH after 35 years of age, exactly we have to take that with a pinch of salt, because we will be missing and repeatedly giving ovulation induction, and we will be adding fuel to the fire. So it is very important. And periconceptional counseling, preconceptional or premarital counseling, we have to tell about this nutrition, proper nutrition, and what kind of lifestyle habits in the environment that plays a great role in keeping the ovarian reserve intact and preventing its decrease. And so protecting decline of ovarian reserve, it prevents chronic metabolic disorders and improves the health of the woman. This is other advantage, even if some other patients with diabetes and hypertension come. Maybe we should check her ovarian reserve. I don't know. In the future, maybe we have to think about it. And repeated ovulation induction leads to decrease in ovarian reserve. So it is very, very essential. This is in our hands. It is very essential to screen for ovarian reserve, irrespective of the age. So as we have to catch them young and use appropriate protocol, ovarian stimulation protocol, or we should think about giving a supplementation with antioxidants to hit at the right place to achieve a pregnancy, as Dr. Ramana Devi Madam has told, Ramani Devi Madam. She shared her experience where she just started ART for that girl and she conceived and she was happy. So we have to screen young women for decreased ovarian reserve and stop doing multiple ovarian stimulation without properly investigating the patient. That is what I want to just convey through my talk. Thank you.
Thank you, madam. That was a very, very elaborate talk about poor ovarian reserve and all the different factors contributing. And we all know that the mothers of today, the mothers who are pregnant today, who are going to bear the female child, they have to take care of their health first. That is the first and the foremost thing from what we say. Yes. And then comes on when the baby is being born and how they are being reared and what healthy habits they are following and what are the environmental factors which are going to kind of affect that. So it's not only the girl who we are seeing today. It starts when she was a fetus in her mom's womb, isn't it? So we have to advise the women who are coming to you now so that the unborn girl childs are protected in future. And environmental pollution is one of the major factors which is affecting these young girls, because we see young girls who are less than 25 years coming with a poor ovarian reserve with the AMH of being less than 0.5. I think Nirmala also would agree with me, like being in the ART centers, how much we are facing, and Ramani Madam would definitely agree as well. Because now our hands are tied up without for using donor oocytes as well with this new laws and regulations, and we got a long line of waiting list for these young girls of what to do with it. So poor ovarian reserve is one of the things which in future needs a lot of addressing. I think if we started today, we'll be able to prevent that crisis in the next 10-15 years down the line. I mean, anybody else can add it.
Oh yeah, there's something interesting that I recently watched on BBC. It's not just us. Apparently, a lot of mammals that are facing extinction in the wild are also having poor ovarian reserve. So it's all these bisphenols and dioxins that Dr. Dasari was talking about that causes inflammatory changes, autophagy, telomerase shortening, blah, 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 all the biochemical changes. That's not just the human. Apparently, it's affecting all mammals, all oocytes. And maybe all sperms as well. Of course, that is going lower and lower by the decade. So, yeah. That's maybe how mankind ends. Who knows? Poor ovarian reserve.
No, it's a long way. We can't think of ending. Thank you.
Papa Madam, it was an excellent, elaborate presentation of poor ovarian reserve.
Sorry, I have taken time, ma'am.
No. It's okay. See, like Nirmala has rightly pointed out, that mammals are going to become extinct. See, we had the opportunity of creating endometriosis in mice. Then, once when the mice were stimulated with where they were given diethylstilbestrol and we induced endometriosis, and when it was again corrected with anti-endometriotic drugs like MMP inhibitors, we found out that the number of litters was prolonged in the mice that had endometriosis when compared to healthy mice. And again, not only the prolongation, usually each mice will give, when during a single litter, it will produce some 8 or 10 mice. But the mice which suffered with endometriosis, they had only 3 or 4. So that means all the environmental, I think more than everything, environmental pollution is going to reduce the reduce the ovarian reserve. See, on the other hand, we have to think about the age-related ovarian reserve. See, even in a young patient with a poor ovarian reserve, if you stimulate with appropriate dose of gonadotropins, I am sure we'll be able to get at least few good quality eggs. See, that is what we find in our practice. No, when you compare a patient with a poor ovarian reserve who is young and who is elderly, the eggs what we get from the young girl is definitely better than what we get in a elderly age person. And I am sure that we even with few oocytes, we can get a pregnancy, we can achieve a pregnancy when the woman is younger. So we have to correlate between the age and the poor ovarian reserve. That is again becoming more important. And then the counseling part, as Madam has also enlightened, Papa Madam has also enlightened that, and Rajapriya in her lecture. So I think this has to be screened. Like, I don't know whether you remember when we had the peak percentage of HIV positivity in our Tamil Nadu, and especially it was in the Namakkal district, all these couple, before planning for pregnancy, they were asked for HIV testing in the registration or registration office. They were made that HIV testing should be done mandatorily prior to registration. So all these things, preconceptional counseling, as well as we have to find out what is the reason, and then manipulating our own methods by appropriately adjusting the gonadotropin dose, and prior to ART, as Madam has said, vitamin C, antioxidants, and then this one, DHEAs helps. And the most important drug, because even DHEAs, we cannot say that all the referrals are for positivity of the DHEAs, and some of the papers say that it's of no use once when the poor ovarian reserve has already occurred. But Eshrey says that Co-D3, that is vitamin D3, has definitely got a positive role. So these are some of the points which I want to highlight in the poor ovarian disease. So ultimately, the protocol has to be individualized when we are planning for ART. Or sometimes what happens is we do come across patients who get married at a very late age, like 37, 38, but they would not have been stimulated so far. So when you take that patient for first time itself, because of the age, when you take them for ART, definitely we can achieve a pregnancy. What Chitra, I think she would agree, because some of our own patients, we had at the age of 36, 37, we were able to achieve at least few oocytes and fertilize, and they have become mothers. Chitra, what is your experience? Unmute.
Yes, true. I agree with you.
Uma and Nirmala, what is your experience? I think you can share as ART consultants.
Yes, ma'am. So here, when I have poor ovarian reserve, I do prescribe DHEAs along with the CoQ 600 milligram.
Yes.
I go for 600 actually, because one of the Eshrey studies told me one of the centers that is in Birmingham, they were using 600. So I also started 600. DHEA 75. And then I also use androgens, especially androgel every alternate days, for the month before doing the ART oocyte stimulation, egg stimulation. What else? We have evidence coming in.
Micronutrients are definitely playing a role in prior to ART. Okay. And what about androgens? You have started this androgen gel.
Yes, I've started using it prior to the stimulation.
What about using this in endometriotic patients? See, in DHA, when you use it for endometriotic patients, that has got a controversial thing. Whether at all we can use estrogens, that is DHA as a precursor. So whether we can use it for endometriosis.
Okay.
Kalpana, what is your experience with androgens for ovarian reserve?
Actually, I have not used androgen, but nowadays, because of new ART bill and strict regulations where we don't have registered a bank, we don't have any other alternatives other than is it audible? My connection is poor, I think. Okay, so I've started using extensively DHEA, but androgen I've not tried because the reviews and Cochrane conclusion was not really towards androgen, because we don't have large database review and how much to use and what are all the side effects. We don't have evidence favoring androgen. So I've not used extensively, but recently I've used extensively DHEA and now trying with PRP also, because we don't have any other alternative. We have to wait for a few more years to get a registered ART bank, and after inspection we can go for donor oocyte also. So,
a few more years. I was hoping you'll say a few more months.
Papa madam, how many months you advise prior to stimulation?
Ma'am, 3 months we are giving and then repeating the
Nothing
AMH,
works
ma'am.
beyond 3 months.
Yes, ma'am, 3 months.
See, if you are going to use it for pump the DHEAs for 6 months,
no,
not
hyper
going to
end, not very
yes.
good.
Only for 3 months we have to use. Okay, so that was a very nice talk by madam, and I think we had some fruitful discussion. Chitra?
Yes, ma'am.
Chitra.
Yeah, always we get confused, Chitra and Chitra and these things. Okay, thank you, ma'am. Thank you, Papa, ma'am, and moderators Uma and Nirmala for this very wonderful discussion. Now we are going for our next topic, that is an panel discussion on adenomyosis infertility. So I like to welcome Dr. Ramani, madam, to moderate this session. And as we already introduced Ramani, madam, and we have an expert for this session, Dr. Gopinath sir, who is an president for the Fertility Prevention Society of India, and he's also a chairman for a board of studies. He's founder of Secretary of IFS Tamil Nadu chapter. He has got his giving a specialist training in fertility preservations, and he's awarded with lot of degrees in ERT. So we like to have you as expert in this field of which is enigmatic topic like adenomyosis infertility, sir. Welcome you, sir. Ma'am, over to you, ma'am.
Okay, thank you, Dr. Chitra. I have great pleasure in welcoming my panelist, Dr. Gajadeepan, who is a chief consultant at ARC International Fertility and Research Center at Trichy. He is from undergraduate from Tirunelveli, MD from AIMS, senior residency from JIPMER, and diploma in reproductive medicine in Kiel, Germany. Presented various papers in national and international conferences, received the Best Paper Award at Fetal Congress Society, New Delhi, India, and his special interest is infertility and laparoscopy. Next, I have Dr. Kalpana Balamurugan from Madurai, who is a senior ART consultant. She is the secretary of MOGS, founder secretary of MCOT, and then course director of postdoctoral fellowship in endogynecology, member of institutional ethics, and principal investigator in clinical trials. Academic profile: invited given guest lecture in more than 50 national and international conferences, organized many conferences and lab workshops, published more than 15 papers, awarded the Best Doctor Award and Golden Excellence International Award by European Continental University, and Medical Excellence Award 2018 from Governor of Tamil Nadu, Best Medical Service Award from Madurai District Collector. Next, Dr. Jayashree, who's a senior consultant in obstetrics and gynecologist from Pondicherry. From Manakular Vinayagar. Chitra, if you want to add anything else.
Yeah, ma'am, she is a professor in Managula Medical College, Pondicherry, ma'am, and she is also a DD training in ERT and also running a very nice ERT center. Very, very good academician. So,
Okay. So the next person is Dr. Nandini, who's Dr. Mary George, winner of Mary George Gold Medal for Best Outgoing Student of CMC Vellore and DG1 MS, TNFOG Youth Award in 2022 for academic contribution, COVID Warrior Award, Anai Teresa Social Service Award, Foxy Comedy Orator. When I was the Vice President, I was very happy to listen to her history and the talk she gave. I still remember that. District Instructor for Indian Academy of Pediatrics, Lactation Consultant, and then active member of Women in Public Sector, Principal Investigator of ICMR and Fluid Research Grant, and presented several papers in national and international conference and published papers on peer-reviewed index journals. Next.
Ma'am, no need of my knowledge told.
Dr. Chitra Tyagaraja, about whom you have already.
Yeah, big CV, big CV.
Yes.
This they got it from last.
Okay. The next, Dr. Chitra, she is a senior consultant in OBGYN and infertility from Lalita Nursing Home, Shamla Nursing Home, and Janani Fertility Center. And she was the past president of Trichy ONG Society, as well as the past secretary and president. And she was the organizing secretary in international conferences, Tech OG at Trichy, which was for the first time we had this from the robotic surgery was done at Chennai Apollo, and we had projected it in Trichy, and that was the first time where we had that satellite transmission. Then she was again an organizing secretary in the first endometriosis conference, which was held at Trichy in 2016, and she is a very good friend of mine with very great academic skills as well as practical achievements, and we both are running the Janani Fertility Center for over a period of 18 years. So welcome Dr. Gopinath sir and all my panelists. Now let me move on to the hope you are able to see my presentation.
Yes, ma'am.
Okay, so all that adenomyosis and endometriosis are deadly duos. Everybody knows March, endometriosis, the month is awareness month is March, but very few knew that April is the awareness month for adenomyosis, and we have a violet or a purple ribbon. So by definition, adenomyosis is the presence of ectopic endometrial glands and stroma within the myometrium. Whenever there is ectopic endometrial stroma, it bleeds during every cycle and starts promoting hyperplasia and hypertrophic reactions surrounding the myometrial tissue. This ultimately leads to the enlargement of the uterus, which also causes severe dysmenorrhea and menorrhagia. So, to start with Gajadiban, are you finding any difference in the changing trend in the age at which we see adenomyosis?
Ma'am, initially the large group of patients were in the within the age group of 35 to 45. The group was more, but nowadays I feel that adenomyotic changes are coming to the late group of 25 to 35. I'm able to see more number of cases recently and coming with infertility issues also, ma'am.
Yes. So, any other opinion?
Yes, ma'am. I think what Gajatiman is telling, there's increasing trend of adenomyosis even in the younger age group. Lot of infertility patients, even at the age of 30 itself, have started having adenomyosis. So, and think associated with endometriosis too.
So previously we thought adenomyosis was a disease that occurs in a multiparous woman. But now we know that occurs even in a nulliparous. That is why we get a lot of young patients with infertility and adenomyosis. And again, these young patients are more prone for association of endometriosis and adenomyosis. Okay, so I think this we have, when we look into the subfertile population, around nearly 25 to 50% of the patients who are coming for treatment of infertility, they are having some basic disease as adenomyosis. So Dr. Chitra, can you enumerate what is the pathogenesis? What is the different pathogenesis in multiparous woman and difference in the nulliparous woman?
Ma'am, the main pathogenesis one is like there is a migration of this endometrium into the myometrium. That's the one thing. And the other thing is that the tissue injury and the repair, which takes place, which is a primary cause of causing this endometriosis, adenomyosis. And this also might affect in the infertility, like it might alter the endometrial expression of this certain inflammatory mediators. That also might be the reason for one of the cause for adenomyosis, ma'am.
So mainly in multiparous woman, there is an uniform enlargement. Okay. Here the main pathology is the problem in the repeated endometrial injury. But whereas in a young patient, that is in a nullipara, there may be the like uterine auto-traumatization occurs. Also, there will be invasion of this endometriotic tissue from the uterovaginal septum. From the posterior aspect, it enters. So mostly we see the posterior wall adenomyosis in association with endometriosis is more common in young girls. Okay. What are the symptoms of adenomyosis, Dr. Chitra? Trichy Chitra.
Severe dysmenorrhea is what we commonly see with them. And then, you know, when you go and find out from their history, then you can ask for dyspareunia and menorrhagia, and especially in older women, yes, they come to you with menorrhagia. But then distinct feature is dysmenorrhea. When you when they come with you with severe dysmenorrhea, you can almost clinch the diagnosis of endometriosis or adenomyosis. That's what
normally when we see the adenomyosis is up to 12 to 14 weeks. But do you think currently you have the same picture or you have a different pattern of size regarding the size?
Sometimes it's this big, sometimes it's even smaller than this. But still the symptoms are very, very severe because probably the additions are more in those patients.
So whenever you have an associated endometriosis symptoms becomes exaggerated. Okay. So then how do you grade adenomyosis, Dr. Kalpana? And do you think that it has got any relevance to infertility? Grade adenomyosis.
Various grading systems, scoring systems are available in the literature. Depending upon the thickness of junctional zone. Sometimes if it is almost 8 to 12, it is graded as mild one, and if it is involving in the middle and total myometrium, it is considered as a severe adenomyosis. If the junctional zone thickness is more than 12, sometimes even 20, it is graded as a more score. The worst, the prognosis will be the worst. So in the early stage, if we diagnose, if the patient comes to us, and if we think about adenomyosis, the earliest we treat, depending upon the symptoms and the need of the patient, either medical treatment, preferably medical treatment, even if she is infertile. So that also is really important, because when the grading is, if the patient is coming to us in a higher grade or with the score greater than 8, the literature says that the pregnancy rates and implantation rates are significantly reduced. Sometimes even with medical management, the patient may not conceive.
Kalpana, that we will come out later. Okay, so as you say, said grading, medial 1/3, middle 1/3, and extending to the outer 1/3. And the other simple definition is it's either a uniform diffuse adenomyosis or a focal adenomyosis. Why we are, what is the significance of this typing and grading of adenomyosis? That you have clearly mentioned. See, the junctional zone thickness, and if it is going to be a diffuse adenomyosis, will it have a better outcome, or a focal adenomyosis, which will have a better outcome? Which one? Focal adenomyosis. So from the grading and from, likewise, when you are grading a minimal grading, that can have a better outcome than a severe bleeding. So next, coming to Gajadeepan, then one more, that is Dr. Nandini is there. Nandini, how does adenomyosis cause infertility or rather subfertility? Because not every woman with adenomyosis is infertile, but they are subfertile. Nandini, where are you?
Yes, ma'am. Yes, ma'am. I'm here, ma'am. See, basically in adenomyosis, most of them may present, it is actually shares the same etiology, more like a endometriosis. So the only difference is this, basically it has various pathophysiological reasons behind it causing a subfertility. So the uterine hyperperistalsis is one reason why, and the second reason is during the transportation of the sperm, it alters the transportation. Also, it affects the implantation process. So the next thing is various gene regulatory mechanism also involved in this process. And as ma'am had initially, Papa ma'am was telling about the ovarian reserve bit of it. It also affects it also has a role on its ovarian reserve. So, and also this, if it is diffuse adenomyosis, so this can cause the problem associated with this etiopathophysiciology, what I have mentioned. But if it's like a adenomyoma where it has a focal lesion, like more of a fibroid, so the implantation failures and increasing incidence of preterm labors, all those things, and the placental implantations, the difficulty in placental implantation, all this can lead to a miscarriages, and the subfertility and infertility component contributed by this.
Nandini, you have rightly pointed out the relationship between adenomyosis and endometriosis. So it is the uterine hyperperistalsis which starts from the junctional zone, it goes again. And then again, the irregularity of the adenomyotic uterus that may cause the tubal alteration and tubal sperm transportation. And as you have rightly pointed out, all the receptivity is altered in adenomyosis because of increased intrauterine ROS. Okay. So the mechanism is intrauterine abnormalities, because you know the cavity of adenomyosis is quite irregular. It has got abnormal uterine peristalsis, and it has got altered endometrial receptivity, and there is abnormal archimetra. See, now we have to understand the myometrium of the normal healthy uterus is totally different. Different from adenomyotic. See, the myocytes of adenomyotic uterus, they have more of this contractile elements. That is why it is in the constant process of contraction and causing auto-traumatization. Okay. So then again at the molecular level, you have said abnormal receptors, progesterone receptors are abnormal altered steroid metabolism, and there is very high presence of pro-inflammatory substances like this prostaglandin, PGR, F2 alpha, then this cytokines and tumor necrosis alpha, and so many things. So this is, in fact, the implantation is also altered. See, this is what, these are the some of the elements which are increased in the utopic endometrium, and it gets decreased. See, the FOXA10 and all, you know that FOXA10 and FOXA genes are very much essential for proper implantation. They are all altered, and pro-inflammatory factors are rather raised. So, what are the ways of treating subfertility in endometriosis? Dr. Gajadeepan, suppose if a patient comes to you with adenomyosis, how do you treat the patient?
Jayashree is also there. Jayashree, where is it?
Just to unmute.
A lot of patients are there for treating adenomyosis and subfertility, like oral contraceptives. But for infertility patients, my drug of choice will be GnRH agonist only. So GnRH agonist can be given for the patients, and we can treat the patients accordingly.
Okay. Dr. Jayashree, you are yet to open up. And so I go ahead with the first case. So this is actually case number 1 should be. So one Mrs. P was 29-year-old. She was married for 1 year and was planning for pregnancy. Okay. Basic investigations and TSH was normal. And she had basic ultrasound on the day 3, which showed adenomyosis of the posterior uterine wall, and ovaries were normal with moderate AC. Male factor was normal. What should be the further plan? Dr. Jayashree.
So moderate antral follicle count. So I may have to go with the AMH, ma'am, to know the, because if
but
she
AMH was only 1.6.
So AMH is low. So I may have to start the patient on she's married for 1 year, so I may have to start the patient on a Dynogest to decrease the thing, or start the patient on DHEAS and go for ovulation induction, because we cannot postpone ovulation induction in these patients.
So any difference of opinion, Dr. Chitra, Puducherry Chitra?
Ma'am, as you already told, like AMH is low in this patient, and she's 29 years old, going to the borderline where user can decrease. And I think main factor is normal. Because it's adenomyosis, why can't we try like, controlled hormone stimulation with IUI for 2 or 3 cycles? If she fails to conceive with this, then I think a role of ERT can be done.
Then Trichy Chitra, what is your opinion? You, Dr. Jayashree has said that she wants to give the patient Dynogest. She is telling you
can we give
totally asymptomatic. She is totally asymptomatic. There is no pain.
She has come with no symptoms, but then she has come only for pregnancy. Because we are seeing adenomyosis there, we can counsel her, and then she's 29 years, border of 30, and 1 year, married 1 year. I'll go straight away, start with ovulation induction, and tell her to go ahead with, if everything seems good, like suppose I get good number of follicles, I'll ask her to go for IUI straight.
Okay, Gajadiban, what is your line of management?
Ma'am, as Chitra said, I will not give any Dynogest for her. Straight away, this patient, I just like to counsel her and give her ovulation induction drugs, and plus or minus, I'll put her on IUA or for 1 or 2 cycles. Probably this will be the first mode of treatment for her, this case, ma'am. If she's not conceiving with that, then I may go ahead with maybe ARTC, I will maybe doing it.
Nandini, what is your, being in a rural area, what will you do?
Basically, the ma'am you have mentioned, it shows adenomyosis only in the posterior wall of the uterus, and the ovaries appears normal with a moderate ASC. So I would actually prefer to do an hysteroscopy to check it whether it is only adenomyosis or is there any component of adenomyoma. And and also considering the hormonal assay is not much into in the rural place, I may prefer to go with the ovulation induction. If that is confirmed, then I'll proceed with the ovulation induction.
See, Nandini, my question is, why do you want to go for hysteroscopy? See, you can go for a ultrasound. Ultrasound is very clear, bulky uterus with a posterior wall adenomyoma. So still you want to go, it's a focal adenomyoma. Still you want to go for hysteroscopy?
Ma'am, it in 2 ways it helps me to visualize the cavity. And it is basically, if it's whether it's obliterating or it's in the posterior wall, I will have the access for this.
That can be found out by simple.
Okay, this ultrasound was not showing a diffuse posterior wall adenomyosis. This was more an adenoma, looking like in one place.
Yes.
Okay.
Okay.
So,
Then we
Kalpana,
plan an adenomyomectomy.
No role for
Not planning for adenomyomectomy.
Okay.
As ma'am said, I may prefer to go straight away with the ovulation induction and proceed further.
Okay. Kalpana, do you want to go for a straight ovulation induction, or do you want to give something else so that her fertility potential might increase?
See, I would like to go for ovulation induction with letrozole, because that is an aromatase inhibitor, and also even though it is focal adenomyosis, especially in the fundus, it is not abstract. Confirmation of is also really important. I would like prefer IUI, even though male factor is normal. I would like to go for IUI in this case because of uterine cyst, the sperm motility is movement is little disturbed in adenomyosis. So I would like to go for ovulation induction with letrozole and also IUI in this patient.
See, suppose if the endomyometrial junction thickness is around 10 millimeter, is it going to change the modality of your treatment? Would you want to
GnRH?
You give GnRH. Then anybody else? So if the endomyometrial junction is going to be more than 8 millimeter, then Gajadiban, what do you give?
Ma'am, if it is 8 mm, I don't give, but
No,
if it is more
okay.
10 mm or more than 10 mm,
okay,
I may give 1 or 2 cycles of GnRH and then go ahead, ma'am.
Even I will
Okay.
do that.
Okay. So now let us see what happened to this patient. I planned her for GnRH analog for 3 doses and ovulation induction. But to our surprise, she came with pregnancy in the same cycle.
Lucky.
This shows that adenomyosis can cause only subfertility. Not all patients with adenomyosis are infertile. So, but it's okay. Now she has conceived. What are the complications we can expect during this particular pregnancy? Dr. Puducherry Chitra. Chitra.
She can have chances of miscarriage. Yeah, Chitra has come.
Abortions can occur, ma'am. Preterm labor can occur, and since there's adenomyosis, there's chances of some placenta abnormalities, placenta adhesions, creta can occur in these patients. Most common is like they'll have failure to conception. If they conceive also, I think the chances of miscarriages are more.
Miscarriage is going to be very high, and premature labor because of increased uterine contractility. And as you rightly pointed out, placental complications can also happen. See, day before yesterday, actually, I delivered this patient. She was my staff. She had an uneventful delivery and the baby was healthy, hale and healthy. So this is a story of a lucky girl with adenomyosis. Okay, now these are the complications: preterm labor, first trimester and second trimester miscarriage because of chronic inflammation, impaired uteroplacental perfusion, placental malposition, preeclampsia, and small for gestational age. These are all the problems they can have. Then coming to the next case, one Mrs. 30-year-old lady was referred to our center with diagnosis of adenomyosis of 14 to 16 weeks. It was a uniform enlargement of the uterus, and she was referred to me for hysterectomy as she was having intolerable dysmenorrhea and AUB. She is again a nulliparous woman, married for 3 years. So what will be the line of management, Dr. Jayashree?
So we can try GnRH agonist for this patient for 3 cycles as a first line of management, and then start ovulation induction also, maybe a long protocol we can start for this patient.
So I will give you some more clue. She was counseled, like how you said, I wanted to give her GnRH analogs because her ovarian reserve was quite adequate and she was only 30 years, married for 3 years. Probably she has not conceived because of the diffuse adenomyosis. Okay, so Gajadiban, what will be your line of management? You agree with Dr. Jayashree?
Ma'am, since she's nulliparous and if she's very eager to have a baby, then she can give GnRH analogs for 2-3 cycles, or we can take her for a long thing and go ahead. But if she's not worried about this thing and only about her symptoms, then I think we can give some levonorgestrel intrauterine system can be given for this patient.
Okay, so Dr. Nandini, what will you do in your setup?
It's again
also. She came and cried, Madam, I am only 30. I don't want to undergo hysterectomy. I don't have an issue. I want to have a baby.
So as the patient is more keen in getting a baby, and also she doesn't want any definitive surgical procedure, it will be better that we give a GnRH for the patient for as Gajadiban had mentioned, it give 2 to 3 cycles. If the patient, and recheck what happens to the size of this adenomyosis and reassess the patient and her symptoms. That too decides what she wants further.
Okay. Anybody else wants to differ? So all of you are GnRH.
Okay. Ma'am, can you give that the role of Mirena or the role of Glycerin?
No. I'm coming. See, if you are going in the size of the uterus is 14 to 16 weeks, if you are going to insert an LNGIUS, it will promptly get expelled. It will fall. So the cutoff limit, what we have is only intrauterine length should be less than 8 centimeters. Then only I will place the Mirena. That is out of my experience we have gained that anything that is greater than that, the expulsion rate of Mirena is going to be high. For this patient, maybe once when you see, then now the next question is GnRH. What GnRH would you prefer? Which is the molecule of GnRH which has got the maximum potency?
Glycerin, madam. Glycerin.
Glycerin.
Having the Zoladex or
Zoladex or Goserelin has got the maximum potency. Do you agree?
Yes.
Yes, ma'am.
All of you? See,
Yes.
we give Leuprolin because the cost is low, but in fact, Goserelin has got the maximum potency. So I have counseled this patient, and then she was counseled for medical management and planned pregnancy later. Her basic investigations on hormone profile were normal. Male factor was normal. She was advised 3 doses of Goserelin, along with that calcium and vitamin D3 and review after 3 doses. Okay, see, then do you start, so here again there is a controversy. Do you want to start on add-back therapy in the first cycle itself, first dose of Goserelin, or you want to delay for 3 doses? Wait for 3
delay
doses.
for 3 doses.
We can wait for 3 doses, ma'am.
We can wait for 3 doses, but you remember that most of our Indian, South Indian population, they are deficient in, they are prone for osteoporosis, and vitamin D deficiency is very, very common. So maybe I will start with calcium and vitamin D3 and add this add-back drug of either a progesterone or sometimes that alendronates if I am going to give it for a prolonged time. See what happened to her. She was again lucky. She came back after 5 months with complaint. See, the 3 doses she has taken Goserelin happily. I had told her you better wait for 1 more cycle and then come when you get your period. She came back after 5 months from the first initial consultation with complaints of vomiting and amenorrhea. And she has already counseled regarding amenorrhea during GnRH analog treatment. And to our surprise, she was pregnant and had an uneventful antenatal period and delivered by LSES. And Uma Velmurugan was the one who did the section when I was away. And she was telling me how difficult it was during the cesarean section because of such a huge adenomyosis. Okay, so, and then later, after that, she had she never had any problem. She was routinely coming for all routine checkups and everything was going on. So this is again a second patient who is lucky enough to have a spontaneous conception following GnRH analog. So then after that, she was so scared of her dysmenorrhea. So now the next advice is put her on LNG. Because in the postnatal period, where there is hypogonadotrophic hypogonadism spontaneously occurring, her uterine size involuted very well and she was inserted LNG IUS. Then after 3 years, she promptly came back to me. She wanted to have a next pregnancy. So what are you going to do?
Take out the LNG IUS.
You remove the LNG IUS. Then
to the antagonist protocol can be started.
Antagonist protocol.
Letrozole induction.
Letrozole induction. So LNG IUS was removed, but again the uterine size was 8 weeks. So now this time, again basic investigations, everything was normal. And as you had, all of you had mentioned, letrozole with gonadotropin was given. And this time I had done an IUI. She again conceived and had a repeat. Okay. Then for the lifelong period that you want to maintain her adenomyosis to get suppressed. So the only modality is continue the patient with LNG IUS. So she is now doing well. So tell me, each one, tell me what are the lessons we learned from this particular case.
Spontaneous conception is possible.
Yes.
I think it's not difficult to conceive in patients who have adenomyosis. There's always a hope for these patients with the medical management.
Yes.
Big uterus, you should reduce the size. Only after that, put in that LNG IUS.
Yes.
GnRH analogs can reduce the size of the adenomyosis and will help in the spontaneous conception as well.
Yes. And no need to go ahead with hysterectomy straight away. Rather than we can put LNG.
Yes.
Yes.
That should be given as an option for all
one
patients.
question. Ramani ma'am.
Yes, yes.
Recently, one of our patients with adenomyosis failed ovulation induction. Somebody advised a surrogate mother. Surrogacy. What is your take on that? And patient was crying, gone into depression.
I am coming to that also. In my subsequent cases, I am discussing surrogacy also. So this particular patient lesson learned from this is we can try to manage medically, then ovulation induction. Okay, so going to the next case, she was a 26-year-old female, married since 3 years. She came to us with primary infertility. Her cycles were irregular. And again, she had ovulation induction. 3 cycles failed outside, 3 cycles of IUI failed, and then HST was done, bilateral tubes were patent, semen analysis was perfectly all right. So then her hormonal profile, she had a very good AMH, almost PCOS. Okay, then LH, FSH, E2, everything was all right. So the diagnosis of primary infertility with PCO, normospermia, repeated failed IUI. So the next option is
unexplained infertility. So
unexplained infertility. Okay.
Yeah.
So then what you are expected to do? Dr. Jayashri madam, I am not seeing you.
Yes, ma'am. I would like to do definitely the diagnostic histolaparoscopy for this patient before I plan for further management, ma'am, because I should be able to give the prognosis for the patient also. So I think I will go ahead with histolap and then plan for ART.
Okay. What about Kalpana? Do you want to go for histolab or straight away go for ART? Because already she had 6 cycles of ovulation induction and 3 IUI.
And what about ultrasound finding?
Ultrasound just showed a bulky uterus, that's all.
Bulky uterus, I don't think if sonographically endometrium is normal and during stimulation there is no evidence of polyp, just because we are thinking and AMH is 7, FSH 6 and 7. Probably if the follicles are good, everything was normal, then I think there is no definitive indication for hysteroscopy. We can directly go for stimulation ART with ultra long protocol also. It can be used because her AMH is very good. We can think about
so
it.
agonistic protocol you want to go ahead. Okay. Then what about Nandini? Are we first justified in taking the patient straight away for ART, bypassing diagnostic histolaparoscopy as Dr. Jayashri had mentioned?
Ma'am, so I also prefer to do a diagnostic histolab prior to ART. Because
what you are going to achieve by diagnostic ultrasonography, I mean diagnostic histolab, I'm telling that uterine cavity is normal, her tubes are patent, ovaries are good volume. And 6 times 6 cycles ovulation induction done, failed.
I want to point out one thing here, ma'am, because I have seen few of my patients who have done hysteroscopy. I could see this tubercle studded endometrium, ma'am. So definitely I would like to see the endometrium, endometrial cavity before going for.
Okay, agreed. Okay, Gajadeepan, any?
Ma'am, actually, I prefer to do a good ultrasonogram, ma'am. Maybe a 3D ultrasonogram can be done. If you are very good in doing a good ultrasonogram, I think there will be no need for a diagnostic laparoscopy straight away.
Okay.
So that is my opinion, ma'am.
Okay. So for this patient,
if at all hysteroscopy, if you have planned, instead of going at this point, we can go for stimulation freeze. She's a case of PCO and also adenomyosis. We can go and freeze the embryos, then go for hysteroscopy instead of going for hysteroscopy at this point. Even if you want to see strawberry points and all those things, it can be done little later before embryo transfer if you have planned for frozen embryo transfer.
Okay, so actually we gave her the option whether she wants to go for a diagnostic histolab or an ART. The patient was willing straight away for ART. So we did a stimulation protocol. This was in last March with a recombinant FSH and HMG for 9 days. We had 24 oocytes retreat because she was a PCOS. Normoazoospermia, she wanted to have only IVF, not ICSI done. And even with IVF, we had 17 embryos. Okay, so it was a good reserve. So on the first day 3 embryos, 8 embryos, freezing done. Day 4, 9 embryos, morula freezing done. And after all, this is a particular patient with a PCOS who is prone for hyperstimulation syndrome. So how do you avoid hyperstimulation in this? What is your practice, Dr. Chitra? Puducherry Chitra?
Ma'am, the one way of preventing the OHS syndrome is, well, like we start with a low dose of gonadotropins 1 and always try to do the frozen embryo transfer, and so always the antagonist protocol for this patient with a low dose gonadotropins, and trigger we like to give it usually agonist trigger is always better.
So this was the antagonist protocol, agonist trigger.
Yeah,
okay.
or is yeah.
We can.
And sometimes posting they tell, ma'am, but I don't know. Sometimes they tell the posting also will affect the oocyte quality, so they
no
don't
need for
advise the
posting.
So and premature retrieval of the oocytes also can be done if you do the estrogen levels are more than 4,000 on a day. These are the things which we can do. And post retrieval, we can do the cabergoline injections, or we can give the GnRH antagonist on day. 1 dose of antagonist trigger also can be given.
So what is your practice, Gajadiban?
As rightly Chitra ma'am said, we will give because since it's an antagonist protocol, we'll give some decapeptyl trigger, and we can give carbogoline can be given, and if required, we can give calcium gluconate also after transfer.
Yes.
And the thing is that we will go for a mild stimulation, not to go with the heavy dose of gonadotropins.
I have given only 100 recombinant and 75, so that is not a high dose. Okay, I expected this. So this was the thing, and then how many of you are using letrozole for treatment of prevention of ovarian hyperstimulation syndrome? See, gabergoline and calcium gluconate are already known, but how have you? Anybody have used letrozole?
No, ma'am.
No. Now, Kalpana, what about you?
Letrozole I have not used previously. I've been using when we are comfortable with long protocol, we can continue Upride, GnRH analogs for another 15 days to reduce the this letrozole. I have not tried.
Metformin can be used, madam. Metformin, some people are using.
Metformin prior to the stimulation. Metformin helps in reducing the ovarian hyperstimulation. Chitra, you share your experience. Trichy Chitra, you share your experience with the use of letrozole in our center.
We usually give letrozole. We give depending upon the BMI. Sometimes it's 5 milligrams, sometimes it's even 7.5 milligrams a day. 3 tablets a day, and we give it for 7 days in a week. I mean 7 days after the pickup. And definitely the incidence of OHS is much low. We combine it with cabergoline.
Yeah, that is our experience. We would have probably used for more than 50 cycles, minimum of 50 cycles. And then we are yet to have any ovarian hyperstimulation syndrome, because it's an aromatase inhibitor. It suppresses everything. So this is the point what I wanted to bring it in this. So here next comes the first FET was done after 2 months. So FET we primed with a HRT cycle, and endometrium was 9 millimeter with the trilaminar on day of 13. And day 3 embryo transfer was done after injection sustained for 100 milligram for 3 cycles, but beta HCG was negative. So we transferred 2 day 3 embryos, but beta HCG was negative. So then how we are going to plan the next one?
And why don't you try for a day 5 embryo blast, ma'am? Blast transfer.
That was the second FET. That was day 5 embryo transfer. We did it, and beta HCG was 50 international units after 15 days, 15th day. So repeat beta HCG was negative. So the diagnosis of biochemical pregnancy was made. So with 2 good embryos, 2 transfers, uneventful, she did not conceive. So this made us think what should be the probable cause for recurrent implantation. Okay. So what next? Huh?
Adenomyosis.
So they detailed ultrasonogram. We did it. It was found to have a diffuse mild adenomyosis with a junctional zone of around 10 millimeter. So probably we thought this was the reason. And then apart from this junctional zone measurement, we did an endometrial microbiome study to rule out tuberculosis infection also. Pre and probiotics were given. Okay, we had some microbiomes which are disturbing the endometrium, and promptly we had given some antibiotics like azithromycin and doxycycline, and everything reverted to normal. So then what should be done? Junctional zone is now 10 millimeter. What are you going to do?
GnRH.
I think we can give 2 doses of GnRH analogs. So we try the 1 more cycle of FET.
Okay. So that was what we did, 2 to 3 doses of C. Then how do you diagnose adenomyosis? It's not a simple like how Gajadhiban has mentioned. We should go in for a detailed ultrasound examination of this one and color Doppler. And again, here we have one more modality that is called as the shear wave velocity. I will tell you what it is. And MRI is indicated only when you have doubtful diagnosis of with ultrasound or color Doppler, and you are particular about the endomyometrial junction. So this is the Musso criteria. Nandini, can you share what is the Musso criteria?
Yes, ma'am. Yeah, a globular or a bulky uterus, it is most of the time present in about 95% of the population. Indistinct endomyometrial junction, asymmetrical thickening of the myometrium, and ill-defined echogenic areas in the myometrium. A junctional zone can be measured and it will be thicker than 12 mm. And the subendometrial hollows will be present, and the cyst in the myometrium of the uterus will be present, and the different appearance of the texture of the myometrium. There is an increased blood flow in the junctional zone and speculated appearance and the myometrial linear striations.
So any three of it, like if you find the junctional zone is thick, or when there is disparity between the anterior wall and the posterior wall thickness, and striations, linear striations, like Venetian blood appearance, then we can say that it is a case of adenomyosis. So when you look into the flow, it is vascularity is very severe, very high. And this is the 3D ultrasound where you can see a diffuse adenomyosis and a focal adenomyosis. This is what is called as the shear wave elastography, where it can pick up the, what does it see? Actually, the stiffness of the muscles, stiffness of the adenomyosis. So now this is an application coming up. Any organ or anything, even in endometriosis, we can apply. And this is a simple way to differentiate endometriosis from a hemorrhagic cyst. Hemorrhagic cyst, what happened? It is not very stiff. But endometriosis, we know it is very stiff. Similarly, the shear wave elastography can pick up very early adenomyosis. Then I said MRI is indicated only when you are not able to get a proper opinion from detailed ultrasound. And here it is very important to assess the junctional zone. So then anything else you can gain for MRI? Anything else? See, MRI is also helpful in tailoring how we are going to proceed. See, if we think about surgical conditions, it can give us an exact site where it can, the lesion is, we can plan our fertility sparing surgeries. Okay, so what next? So this patient, we now come to a conclusion that she has got an early adenomyosis, and then leupride was given for 3 shots. So now my next question is, when will you start preparing for FET? You wait for the next periods to come, or you start on the 28th day of the last leuprolin?
Start after that. We can start, I think, because anyway we are going to give HRT only. So we can start after the 28th day.
28th day. So there has been again lot of studies to compare when you wait for 1 cycle and then start an FET, that doesn't yield a better result than continuing the patient on, like on the 28th day of the last dose, you start the patient on FET cycle. So this patient had an FET preparation with the estradiol valerate. Endometrium was 9 mm, and this time we transferred a day 5 single embryo transfer. Okay, then supported, and beta HCG was found to be 247 after 14 days, and after 1 week she had a beautiful intrauterine sac, and after 2 weeks that we had a FH, and this patient is doing very well. Okay, so now she's continuing her pregnancy. So now what is the IVF protocol which is suitable for this particular patient? I think that we have discussed. So that we have discussed either an agonistic protocol
or
which will not be ideal, but antagonist protocol is safe. But ultimately, what the literature evidence says is there is no one protocol is superior to the other one. Okay, so this was the ultra long protocol with the other protocols, and the clinical pregnancy rate, miscarriage rate, and live birth rate are the same. So now tell me, each one of you tell me, what are the lessons learned from this particular patient?
So when there is recurrent implantation failure, we always have to think about adenomyosis.
Adenomyosis.
Do ultrasound and
you
review
tell
our ultrasound findings.
Okay, then next.
Confirm the diagnosis by ultrasound, a detailed ultrasound or a 3D ultrasound with a color Doppler will be much helpful rather than going for immediately for a diagnostic lab or an MRI.
Okay, then
assess the zonal thickness.
That
Junctional
is
zone
very
thickness.
important.
That will
Zonal
decide.
thickness is very, very important. Then
heavy luteal
anything else?
Just
Heavy
because
luteal
ultrasound is
support.
made, I
Always
think
for
don't jump
any
to
endometriosis and adenomyosis patient, heavy luteal support is essential, but these people have basically estrogen deficient. Okay, then two-stage ART, that is what we have done. See, how many of you prefer a HRT cycle and how many of you want to go for a modified natural cycle? Which you think is better?
I think modified natural cycle is better, madam. Most of the studies have shown that modified natural cycle is better than HRT cycle. But most of me practice HRT cycle only. Though we tell it isn't.
Kalpana, what is your experience with the natural, modified natural cycle? Kalpana is not there. Yeah, Kalpana, tell
If the
me.
thickness is less or something, we can go for modified.
Yes, if you don't have a proper thickness, doing a HRT, endometrial thickness is not achieved, maybe modified natural protocol may be better. Okay, so let us move on to the next case. This is a very interesting patient. She was a 42-year-old patient, secondary infertility, referred for myomectomy. Married for 3 years, it was early marriage. She had regular menstrual cycle with severe dysmenorrhea. Then one history of miscarriage with the DNC done through the first marriage. On clinical examination, uterus was enlarged to 10 to 12 weeks size. Repeat ultrasonogram in our center showed it was a posterior uterine adenomyosis and the volume of the uterus was around 200 cc. So because they had referred as a case of myoma, I wanted to reconfirm and I did an MRI which confirmed that it was adenomyosis. She had frozen donor oocyte embryo waiting for transfer in different center. So what to do for this particular patient?
For this,
tell me.
Ma'am, for this patient, already she's 42 years and she's having the embryo waited for transfer. And there was a confusion between whether to go for a myomectomy and you did a MRI and confirmed it is an adenomyotic. I think better you do a diagnostic laparohysteroscopy. If you find it is going to be adenomyosis, you can see whether it's how much size is the adenomyosis, whether focal adenomyosis or a diffuse. If it is focal and it is significantly larger, I think at least you can do a focal adenomyomectomy and downregulate her with GnRH agonist for 2 cycles and go for the transfer.
Anybody else want to differ? See, she hasn't had even one miscarriage. That's all. That too when she through the first marriage when she was young. Now she has an embryo waiting for her to get transferred, and it is quite a posterior adenomyoma, and the uterine size was 200 cc. And I'll tell you one more clue. The cavity was not distorted. It was exclusively in the posterior uterine wall. Still, you want to go for anybody wants to go for surgery?
No. Ma'am, we can give again GnRH agonist also or something. We can give for 2 doses, which can help in reducing the size. So that will also help in what you call receptive of this frozen embryo transfer.
Somebody else was talking about hysteroscopy in the previous case. So would you like to do a hysteroscopy for this particular patient?
Yeah.
Jayashree, I think.
Why?
Definitely, ma'am. Hysteroscopy has to be done.
Hysteroscopy is a must because of the irregularity of the thing. We need to identify what is the direction. Is there any adenomyotic tissue jetting inside the uterine cavity? All those things. So hysteroscopy is a must for this patient. So what is the mode of treatment? I agree with Dr. Chitra that medical management is the treatment. And Gajadiban, I think surgical management can be deferred if it is not responding to medical management. So the volume is 200 cc. Now, what is the expected volume you should reach? Normal volume of uterus is around 70 to 80. So at least if it is coming to may not be able to reach a normal size, maybe 100.
100.
Okay. Okay, so she was planned for hysteroscopy and the cavity was large, directed posteriorly. And I did an endometrial sampling which was positive for mycobacteria. So this is an added negative point. So now naturally I have to start treating her with antituberculous drugs. And simultaneously after 3 months, I started her with goserelin. And here this time along with goserelin, I added letrozole and dinegest. What is the idea of adding letrozole and dinegest along with goserelin?
To prevent ovarian hyperstimulation. But anyway,
No.
So embryo transfer.
So I want to prepare her uterus for embryo transfer. See, again, there are studies to show that combination of goserelin with letrozole reduce the ovarian volume much rapidly than goserelin alone. Okay, so with that idea, I gave her the two drugs together. But with both the drugs have got severe vasomotor symptoms. So we need to supplement with an add-back therapy with progestin. So then I thought, why not we start this patient with dinegest? Because it's a progesterone derivative. So this particular, and again, dinegest has got an anti-inflammatory effect, it inhibits the tumor necrosis alpha, anti-VEGF, and then all these adenomyotic adverse effects are all going to get suppressed. So added with calcium and vitamin D3. Now, after 3 doses, the size are reduced to 120 cc. Okay. Then when I measured the endomyometrial junction, it has thinned out. What was earlier beyond 12 millimeter, now it has thinned out. And see, this is a hysteroscopic view where you can see a irregular cavity and jetting of the posterior wall. So this she had some irregular cavity, endometrial defects, strawberry appearance, hemostatic deposit. So all these findings were seen. So these are all some of the findings. Now, let me come to one practical classification by our own Dr. Sunita Tandalbarkar, where she says, when you grade 1, she calls when it is less than the adenomyoma size is less than 4 centimeters and when it is away from endometrial cavity, or when it is again less than 4 centimeters but compressing or touching the cavity, both should be treated only medically. Do you want to go for a surgical management when the adenomyoma is just 4 centimeters? No, we can very well manage it medically. Okay. So then the second grade 2, she says, it is 4 centimeters away from the cavity. And then more than 4 centimeters, but compressing the cavity or touching. So anything that touching the cavity or alters the endometrial cavity, these are the patients, they need surgery. Okay. Then comes the grade C, where there is a diffuse adenomyosis. For diffuse adenomyosis, what you are going to do?
That's all. You can only give medical management, can't do cutting.
Yeah, medical management, long-term medical management, and failing which the patient may need surrogacy. Dr. Gajadiban, do you think that you can plan for some other surgical management for diffuse adenomyosis?
Ma'am, diffuse adenomyosis, I don't go for any surgical management, ma'am, for this.
So your management is going to be only medical management. Or the last one is they may need surrogacy. Okay. But there are few surgical techniques that has been followed by some of the Chinese colleagues. Anybody knows about Osada
procedure?
Osada techniques, where he puts like I can show you that Osada.
Debulk the adenomyoma and then reconstruct the printing.
Yes, I can show. Debulking.
Triple flap technique.
Osada's technique is this one, triple flap technique, or there is another 4-petal technique has come out in a way, or when it is going to be a focal adenomyoma, you can excise only the focal things. Okay, these are all the things. But after surgery, how long do you want to wait? How long do you want to wait after surgery?
3 months.
At least 3 months.
At least for a period of 3 months. And during that period, do you want to give GnRH prior to surgery or after surgery?
After surgery, we want to give, ma'am, at least 2
after
doses.
Surgery, you want to give. Even prior surgery, it can be given because we do the surgery when it is not responding to medical management. Okay, so this this I have already mentioned GnRH analogs. The advantage of GnRH analog over surgery is main thing is the incidence of rupture following adenomyomectomy is 1 in 8. So this has got the reduced incidence of rupture. So this is always better. And there are so many studies to show that even with a simple GnRH analog, like in my previous patient, spontaneous conceptions have occurred. Then again, aromatase inhibitor. This is the study by Kimura et al. Shows that combined use of aromatase with GnRH has got very much reduction. And dynages has symptomatically, it can improve the pain and the bleeding, but not much in the volume part of it. So this particular patient is now, she is treated for her anti-tuberculous treatment, 6 months course over. Her volume has now come down to 120 and endomyometrial thickness is thinned out because of continuous down regulation. So now how we are going to, as I said earlier, FET cycles, hormonal thing is going to get started on the 20th day after last dose. Okay. So similarly, we prepared 2 blasts of A grade were transferred, and again high luteal support was given, and beta HCG was positive with a value of 3,670. After 7 days, she showed twin gestational sac and both had FH. See, are you happy or are you not happy?
Happy, ma'am. I just have a small thing, ma'am. While doing an embryo transfer in adenomyotic patient, while doing an embryo transfer, before the embryo transfer, do you like to give any tocolytics like atosibon or something to prevent that?
Now I am coming for that again. What are the precautions, like rightly now you have pointed out, what are the precautions you should take prior to transfer, embryo transfer in adenomyosis? You come ahead. So you said atosibon. How many of you are using atosibon for adenomyotic patients? No, even I have not used. But that is how the literature says. What it says is you should watch for the endomyometrial contraction. Okay, so if the contractions are going to be more, then there is reason to use atosibon. See, apart from that, what are the other precautions you want to take? See, is it like a simple embryo transfer, like a male factor or a tubal factor, or is it difficult?
Difficult, ma'am. The transfer should be very neat and clean, and be very careful and gentle because the length of the this thing will be very larger.
So mock transfer is very, very essential. Okay, mock transfer. Then ultrasound guidance, and then
that's what, when you do the mock transfer, you measure the uterine cervical length, and then you mark it on your catheter and fix it according to that, and don't go and search and negotiate yours. You should know in which direction your catheter should go, and all that should be marked on your case sheet so that you find it easy on that day.
So that is why pre-transfer histoscopy becomes a must. Length of the ET catheter should be adjusted, antispasmolytic should be given, and atosibon. Most important thing is single embryo transfer should be done.
You didn't do that.
Why? Why? Because miscarriage rates are going to be high, preterm labor is going to be high, preeclampsia. So probably if I had done it myself, because the embryo was stored in some other place, I would have preferred only a single embryo transfer. But anyway, she is now 14 weeks of pregnancy, doing well. Hopefully, I will take her at least to 32 weeks of gestation. So now you tell me what are the lessons learned.
Adenomyosis, volume of the uterus should be reduced. So that should be the first we should take. At least from whatever 50% of previous this thing, because in this case from 200 to it has come to 100 cc. So at least we should try to achieve that. From one doubt here, if we are not able to achieve this volume reduction in 3 months, are we justified in prolonging the treatment?
We can extend to another 3 months. We can extend. Okay. So I think we can finish with this.
What is your experience
in? Experience in? Sir, Dr. Gopinath sir,
My connection is very poor. Sorry to interrupt. What is the combination of drugs you have used? GnRH analogs and letrozole. What is your experience in LNG-IUS and GnRH analogs? Can it be used?
Yes.
Progesterone
GnRH analog prior to inserting.
Can I take that question, Ramni?
Yes. Yes, sir. Yes, sir.
Yeah. See, the first important, let me just answer this question and then come to my comment. So anything prior to an IVF, an embryo transfer, to put it inside the uterine cavity, I will think twice. So if I have other methods of attacking the adenomyosis, I will always go for it rather than putting the IUCD there before an embryo transfer. And to give an overall comment on this, it has been very nicely dealt. Different case scenarios has been just discussed in detail, and various views have been discussed in detail. The panelists have taken that efforts to put their opinions. Regarding the incidence of adenomyosis, we all thought it is a disease of 6th and 5th decade, but today we even see adenomyosis in an unwed woman, especially with primary infertility. Prior to that IVF stimulations, at the time of the embryo transfer, we get crude shocks by looking at the adenomyosis, which could be either a focal or it could be a general. So it is really a nightmare. To make a diagnosis of adenomyosis, you don't have to go in for such detailed, elaborate things. As it has been pointed out in the panel, just a good ultrasound with a color Doppler should be more than sufficient. Do not go for the extensive investigations. That is number one. Number two, I would prefer to do it. I will not go in for an MRI because MRI has got an advantage when you are just going for either an MRI focused IFU or an IFU rather than just doing a surgery or on a medical treatment. That will be suffice to do it only with the normal color Doppler. Regarding the medical management, so we discussed various methods. So ideal will be a gosserelin to reduce the volume, and the recent development of adding an letrozole is justified because letrozole produces a hypoestrogenic status where stimulus for the adenomyosis is reduced. Thereby, there is a shrinkage of the volume is there. Regarding the IVF stimulation, as we just mentioned about the mock transfers, we also have to look at the accessibility of the ovaries at the time on the basal scan. And another important aspect is whenever you are deferring an embryo transfer, whenever you are going for a segmented IVF, that is the time to go in for a GnRH trigger.
Yes.
If you feel your yield is going to be less and you want to finish with that particular thing, better not to go in for GnRH, the agonist trigger. So probably you can straight away go. If you feel your oocyte yield is limited, where you don't want to just waste that time because the patient is old, then probably it is best to go in for only a normal HCG trigger. And regarding the stimulation, the preparation, the pre-treatment with GnRH analog on the 21st day, followed by an HCG cycle is more ideal. When you don't have a good sufficient endometrium, either on the basal level or on the thing, then probably you can go up see for a modified transfer. Most of us are able to get a good endometrium on an adenomyotic patients with GnRH analog and an HRT cycle. So we go by that. As Ramani has pointed out, you do not waste your time. Don't hesitate to put on a very strong luteal support here. And there are a lot of papers coming out with the use of atosibond prior to the thing. But one thing I have seen it in mine, I have not used it at all. So you can just go in for a very nice way. You do a transvaginal ultrasound. You take a videographic recording and then play it in about some 1/6 of the speed. And then you will be able to look at the wavy pattern of the myometrium, and then you will be able to see whether you need atosibon or not. This is a very simple way in which you will be able to do it by yourself. That will be one of the very useful things. And about the transfers, and don't ever think that it is going to be a difficult transfer. Please go ahead, think simple, and then go for a simple transfer. As Ramani has mentioned it, go for only a single day 5 transfer. So that is the most important thing. And do not go in for a multiple transfer, and don't hesitate to go in for a day 5 transfer. Make sure that the embryo is not the cause, only the adenomyosis is the cause by taking it to the day 5.
Thank you, sir.
Thank you very much for your comments, Dr. Gopinath. We really see, that is what I said. 40% of the elderly women who are coming for ART, they have adenomyosis. Okay, then HIFU only when you, then what is your take about doing an HIFU for reducing the size and then going in for an ART?
I have got a very good experience. I have had my own hands-on training on HIFU in China. We were about to procure that machine, the first of its kind in Sims Hospital, but exactly about 2 months later, our COVID broke out. And then after that, we were hesitant to just go in for any investments. And right now, I have been doing HIFU with Malaysia. So Selva is doing my patients. So anytime when I have a global or a focal adenomyosis where the patient can afford, I send him to Selva, and Selva is doing a HIFU and sending the patient back to me. We have got excellent results, excellent shrinkage, and then we have got a positive pregnancy rates. So, but it should be restricted to the patient where you cannot handle it. Don't take it as a routine, because it is not. I have done some of the cases in Coimbatore when I was there with Dr. Mirdabashni. We have been doing an MRI, but at present that machine is not working, so we are not able to proceed with that.
How long you wait, sir, after a HIFU?
After a HIFU, 3 months is the waiting period.
Okay, like any other thing.
Then what about
you get
the
a very
ovarian
good
reserve? Ovarian reserve.
No, the ovarian reserve is not altered. That is number one. Your endometrial thickness will be very, very good after the HIFU.
Okay.
Does the patient go for amenorrhea after that?
No, they don't go in for amenorrhea. Soon after because we are not using a GnRH analog and we are not using a letrozole on that. So soon after the HIFU, they get the periods regularly, and then it will be, the first period will be slightly on the heavier side. Probably you can understand it's because of the pelvic congestion. And then in the second and third period will be normal. And then you just, after the 3 months, you have a basal study and then try to take them out.
Okay.
But it's quite expensive. In Indian rupee, in Malaysia, for you to have an HIFU and come back, it takes about 4 lakhs.
Okay.
Thank you. I have a meeting to attend. Please excuse me, Ramani.
Thank you, sir. Thank you,
Thank you.
for your expert comments. I think we had a very fruitful discussion, and I thank all my panelists as well as the IFS South Tamil Nadu and Pondicherry for giving the opportunity. Thank you. Thank you.
Ramani, you showed your class as the chairman of the endometriotic committee.
Sir, 2 minutes, sir. We'll have a vote of thanks, Gopinath sir. So,
Yes.
ma'am, I'm one sincere apologist, like I was not able to put up the CV of Jayashree and Papa ma'am because of some miscommunication logistic issues. So I like the tech team, please to put up the CV of Dr. Jayashree. And meanwhile, I really thank all these speakers and yeah, this is Papa ma'am's. Ma'am has a qualifications of she has did fellowship in reproductive medicine. She's an teaching experience of 32 years. She has got lot of awards to her credit, like she has got Best Paper Award in Indian Journal, in ALCOG, and in
Please,
obstetric
please,
medicine.
it is not necessary. Please, please close it. What is this?
So,
What is
Bit
this?
of CV.
I
no, madam, the
introduced
CV is
myself.
they missed,
No,
madam.
please.
Jaishi's
This
and
is
yours.
very unpleasant situation. Why should you put up my CV now at the end?
Okay, please put up Jaishi's
All
CV.
Tamil Nadu people, Gopinath sir, Ramani madam, everybody knows me. There is no need to put up now.
Dr. Jaishi is a professor and she has did a certificate course in infertility, and she is also undergone National Teachers Training Program and professor of head of department, and she's a deputy medical superintendent in Managala Vinayaka Medical College. She has a teaching experience 7 years and she is running a very beautiful ART lab, and these are the two things. These are experts in the field of reproductive medicine. Thank you so much, and once again sincere apologies. Yeah. So on behalf of, I really sincere thanks to Ramani madam, Rajapriya ma'am for initiating this infertility webinar and taking up this responsibility and guiding me. And I thank the speakers, the chairpersons and all the panelists. And a sincere thanks to Gopinath sir for coming and giving a lot of inputs, and I had a wonderful discussion, sir. Thank you so much. Thank you one and all.
Thank you. Thank you.
Thank you. Thank you, sir. Thank you so much.
Thank you, ma'am.
Thank you.
sir.
Thank you, everyone.
And finally, thanks to Shield.
Ma'am, Shield, Dr. Chitrakala,
And
Dr.
Mr.
Stalin,
Balaji is
Balaji,
also
sir.
with us.
Yeah.
Whenever we say that we
Actually,
want
I've
to-
never had any interaction with the team. So I'm seeing the first time. So thank you so much, sir. Thank you.
Thank you. Thank you very much, Dr. Ramani madam. Thanks. Gopinath sir, thank you very much. Thanks,
And
everyone.
thanks to all the panelists. Thanks to all the panelists. Okay. Okay, Chitra.
Oh, thank you, ma'am. Thank you. Thank you, Gajadeepan. Nandini,
Thank you, ma'am. Thank you, sir.
Balaji sir, சொல்லுங்க.
Ramani madam, நீங்க ஒரு program சொன்னீங்க இல்லையா, start பண்றதுக்கு முன்னால, you were telling me you have initiated a